Good morning and welcome to everyone. Thank you for giving up your Saturday morning to join us here today. This is the 22nd of our lecture series, and I've been running them for 14 or 15 years now, and really there was no way that last year we could have predicted that we wouldn't be able to meet face to face over so many years. Now, the webinar numbers have been steadily growing over the last few years, and so hopefully we've learned enough lessons from that to be able to transition over to a completely online experience for you. Now, normally the guys at the university run our tech and we're doing it ourselves, so hopefully you'll excuse any hiccups with the technology we have along the way. Our thoughts certainly go out to all that have been affected by COVID, and we hope that you and your families are staying well. And we're particularly pleased to see that our Melbourne participants are starting to head back to a more normal life now. If for any reason you can't stay to watch the whole program today, I believe you can actually pause the live stream and come back and continue watching where you left off. And the link that you have to the YouTube live stream should actually allow you to rewatch the event once it's fully uploaded, but I'm not sure exactly how long that's going to take. So we've got a star-studded lineup today, and we're going to go through quite a few different topics from spine, shoulder, knee, as well as some sports medicine topics, and ones that are sort of somewhat lighter and interesting. So we hope you enjoy it. Now, clearly there won't be a tea break, and you can pause it when you want to. We will be having some discussion in between cases and answering as many questions as we can. You will have noticed that not all the lectures have handouts this year, which is fine, and if you're looking for a PDF of the handout, you'll be able to find it on the website or get in touch with Catherine. So we have quite a few international viewers ranging from North America through Europe, as well as Asia, New Zealand, and all parts of Australia. And within Australia and New Zealand, you can see there's quite a diverse group, and particularly within the Sydney Basin, you see there's quite a few of you here. So the yellow circles show you the locations of the Orthosports offices, which covers southwestern Sydney, as well as the Penrith and Bella Vista regions, as well as eastern Sydney. So there's Randwick, Hurstville, Concord, Bella Vista, and Penrith. Each location has both sports medicine physicians and orthopaedic surgeons, and we have x-ray facilities at all of our locations, which makes the patient experience far smoother because they don't have to go away and come back. So there are 5 practices, as I mentioned: surgeons, sports physicians, and we are a subspecialty practice. And because we are, it means that any patient you refer to us, we can take care of completely without them having to go outside the practice, as we cover all body parts. Here are just some photographs of the various offices. The doctors at Orthosports are committed to ongoing education, with most of us having at least a public hospital or university appointment to facilitate teaching to trainees in various fields. And before COVID, we welcomed as many of you to theatres and to our rooms as possible. We have to be a little bit more selective now about which lists people can come to, but we're still very happy for you to come with us and then see why we rehab people in a particular way and discuss them. What is probably a little bit easier at the moment is to arrange smaller visits by one of our doctors to your practice, if you've got a group practice, and we can come and do some didactic or more interestingly Q&A sessions with you guys. So Catherine can organise that for you. We're very proud to have been continuously accredited by the College of General Practitioners as a Category 1 education provider, and as far as I know, we're the only private practice in Australia to have actually achieved this. So we've had over 2,000 general practitioners attend our education seminars, and hopefully this has improved the quality of the referrals that they provide and the quality of care they provide to their patients. The teaching session of our website is regularly uploaded, and we're always looking for feedback as to how to improve things, and we really would appreciate it if you could provide that feedback for us. So here's just a link to the website. It's orthosports.com.au, and we've modified the format of each year based on the feedback that you guys have provided. So please take some time to go to the 2020 Ortho Update link and provide that feedback for us. Now, in the past, at the end of this, there's been the code to get your CME certificate, but what we're going to do at the end of the lectures today is I'll give you the code, and if you just email that code to education@orthosports.com.au, Catherine will reply with your attendance certificate. You don't need to remember it. I'll provide it right at the end of the lectures. I'd just like to take a minute to thank DJO and Calcere Imaging for their support over the last few years. And while Orthosports is covering everything today, we look forward to having them back as sponsors when we have our next live event, hopefully next year. A last reminder, we send out a monthly email with an interesting question and answer, and we look forward to receiving more questions from you to be able to answer. So on with our day, and we're going to start with the first of our lectures, and I'll see you soon. So with me this morning are Dr. John Best, a sports medicine and exercise physician, and Dr. Paul Mason, also another sports medicine and exercise physician. Hi guys, how are you this morning?
Very well, thanks, John.
Yep, good morning, Doron. Hi, Paul.
It's good to see that we're all sitting in our houses with our appropriate backgrounds here. I'm in the library of my house. Paul's up in the loft. John, where are you this morning?
I'm in my wife's study.
Okay,
she's the one with the books. I thought you scaled down, Doron, your home. It doesn't look...
No, not at all. We're going crazy right now. Anyway, John, thanks for being with us. Would you mind now just stepping up and giving us your talk this morning? You're talking about the stiff, painful shoulder, I believe. Is that right?
That's correct. No, it's a pleasure. Thank you for having me.
All right.
Hello there. My name is Dr. John Best, and I'm a sports and exercise physician at Orthosports Randwick. I've been there 30 years, which has been a great pleasure and professional satisfaction. I'm sorry we can't meet as a group today, as we've done with what we call our big day out, our orthopaedic and sports medicine update. But wherever you are, we hope that you find this presentation and ours as a group helpful as we care for our patients. I just briefly want to acknowledge patients and also those of you professionally who have struggled through COVID. It's been such an unusual year with some difficult times ahead. We feel for you. We hope that both health-wise, you and your families can get through this, and also professionally, you're not too severely affected. There's a handout you have with you which is a good summary of the presentations I'm giving. So I'm looking at an approach to the stiffening, painful shoulder, and on that handout will be information about historical presentations, some variations in history, and also physical examination features. Shortly I'll go through the physical examination with our subject, Richmond, an exercise physiologist who I'll introduce, but I'd like just to go through my approach to aspects of the history. As a heads up, again a precursor, and it's the case with all musculoskeletal pain, don't forget your red flags. The patients who present with associated fever, debilitating night pain or neurological symptoms, which is not unusual with shoulder pain, as you know. And indeed, many shoulder conditions present also with pain at night. But just keep in mind, if it's atypical, it may be a feature of an infective process, an inflammatory process, or a malignancy, all red flags. The night pain may be severe with rotator cuff tears, glenohumeral arthritis, AC joint arthritis, but also capsulitis of the shoulder. When we look at the stiffening, painful shoulder, we can split the patients demographically, by and large, in those above and below the age of 40. By and large, those under the age of 40 will have shoulder impingement. The variety of that is external impingement, so the subacromial bursa being compressed under the acromial arch. There may be associated rotator cuff pathology with that. And also in younger people, acromioclavicular joint synovitis with or without arthritis. With both of those conditions, the long head of biceps may be irritable. It's usually not the main driver of pain, but it tends to be associated with those pathologies. With patients over 40, we can have the diagnoses I've mentioned, but in addition to that, adhesive capsulitis should be considered, particularly in females. Glenohumeral osteoarthritis should be considered, and you don't have to be elderly for that. And then finally, with all of those conditions, don't forget calcific tendonitis as a cause of acute or subacute shoulder pain. I always x-ray patients who have a stiffening, painful shoulder. An x-ray is a good test to exclude things and also gives you some information regarding the architecture of the shoulder. What about history taking? With our history taking, it's good to get the patient's background in terms of what they've done before with their sports, what they're doing now, and what they're doing in the future. Their work and physical capacity around the house is important with that as well. Has there been an acute injury? Is there a chronic or overuse problem? The history of a previous glenohumeral instability episode is highly relevant. So patients who've had a previous glenohumeral dislocation or subluxation and may go on to have further instability frequently have glenohumeral osteoarthritis, which does not always show up on the x-ray. These patients may be in their 40s or early 50s, and that diagnosis tends to surprise them. Please keep that in mind in terms of past history. In addition to that, if there is rotator cuff pathology, if that degenerates further, cuff tear arthropathy may develop where the humeral head rises up and degeneration occurs within the shoulder. Take a bit more time getting an overview of your patient holistically. Do they have a personal history of certain metabolic disorders which are associated with many shoulder conditions? For example, conditions such as diabetes, thyroid dysfunction, Parkinson's disease, gout, hemochromatosis, which is an iron deposition disorder. They may all coexist with adhesive capsulitis of the shoulder. Take a family history. Is there a history of osteoarthritis or other arthropathies? Are there any inflammatory conditions that occur within the family? Conditions such as rheumatoid or lupus. All of these are relevant to give you a profile of the patient. The other thing that's worth mentioning is the role of their diet and inflammation, particularly in relation to tendon disorders, tendinopathy, and osteoarthritis. Patients who are metabolically unwell, particularly those who use a lot of processed food and are in the overweight or obese category, that contributes very, very much to their inflammation and needs to be kept in mind with that. One of the last things in the history that's worth looking at is their response to treatment. By and large, patients who are in the inflammatory phase of adhesive capsulitis or have a highly irritable bursa in the subacromial space or have acute synovitis in the shoulder with glenohumeral arthritis, by and large, they tend to get worse with physical therapy. Down the track, physical therapy will help them. And finally, have they had injections? So a patient who's had a good quality subacromial injection with cortisone and local anaesthetic, if they haven't had any improvement at all, you've got to rethink your diagnosis. Many of these patients really despair. My most unhappy shoulder patients are my capsulitis patients, particularly in that overlap of night pain, movement restriction, fatigue, can't exercise. You've all seen these people and they need compassion and a lot of education. Finally, as we treat our patients, it's always good to find out what their expectations are. Night pain creates a lot of fear. You need to let people know whether or not this is going to be a chronic problem, what they can do as they recover, what they can look forward to as they recover. So, with these thoughts in mind, I'm going to ask our subject, Richmond, to come forward and I'll introduce him as I examine him. With these introductory thoughts, let's examine our subject, Richmond Saliba from EPS in Sydney, Exercise Physiology Sydney. Richmond, thanks for helping us out. So the first thing I would do is observe the patient's movements and their ability to dress and undress. As you know, with adhesive capsulitis and osteoarthritis, hygiene is difficult. Washing the hair for females, putting on and removing a bra, and so on. So I'll ask Richmond just to take his shirt off for me. And he's got right shoulder pain, which we're assessing today. He seems to be nursing that a little bit. Then I would observe his position and stance. I'm looking for any swelling or asymmetry. Frequently with osteoarthritis of the AC joint, you can have swelling there. He's got slight trapezius elevation and possible spasm, which we'll keep in the back of our mind, but there is no appreciable wasting. I'll be examining him posteriorly in a moment, but while we're standing here, so we're not moving around too much, I'll go through his active motion. So just putting your arms into the side, like this. We'll start with your left arm turning out towards me. That's good, and back in, and the right side the same. And he has some restriction in internal rotation. Arms down, please. The left arm, again, always doing the arms separately, lifting forward as high as you can. He's got a good range of motion there. And the right side, just take it till he's hitching his shoulder, as you can see, and has some restriction. I'll then look at him from the back, so turn around, looking back towards the camera, and looking at any asymmetry, and as you can see, his right trapezius is hyperactive. Relax for me. Good. Pull your shoulder blades together. I'm looking at size of rhomboid in that position. Relax again, and then I'll look at scapular rhythm. So just lifting both your arms forward to just above shoulder height, and he has a degree of dyskinesis with that. Come down. We'll do it again in slight abduction. Come out towards, that's it, and he hitches at that point. So in his age group, I would be thinking of shoulder impingement that's severe, possibly with some early capsulitis developing, but we'll move ahead and see what we can find. While the patient has their back to me, I like to assess subscapularis and look at whether there's any deficiency in power by performing a lift-off test. So we'll start with the good side and pushing your hand up off your back against me, and that's strong. And this side here, there's a little bit of pain, he's grimaced. So I'll lower the arm a little to make it more comfortable and then lift it off your back for me. And he's a little bit weak there. Now, at this stage, so just turn around, thank you, Richmond. We've got restriction of active motion. We have slight irritability of the subscapularis. And at this stage, I would move then on to palpation of the shoulder. Moving on to palpation, the superior landmarks of the shoulder are not difficult to find at all, even in obese or overweight patients. Obviously, we've observed movement patterns, we've observed for asymmetry, we've observed for swelling. So I would start by palpating the clavicle from the sternoclavicular joint to the acromioclavicular joint. And as I palpate the acromioclavicular joint, and just remember, it's quite a broad joint, so you can palpate it posteriorly, superiorly and anteriorly. The patient will tell you if they have pain. I'll move on from there, noticing that the patient has 2 surgical scars, and palpate the long head of biceps. Again, this can be quite tender, so it's worth comparing it to the other side. As I move, I'll move across to the greater tuberosity if there's any insertional supraspinatus tendon pathology. Occasionally, the subacromial bursa is quite large, and you can have tenderness on palpation of it. And then I'll move to the back of the shoulder, the posterior glenohumeral joint, which may be tender with adhesive capsulitis or glenohumeral osteoarthritis, where there is an effusion. I then perform in the seated position some impingement signs. The near impingement sign, NEER, involves direct compression on the acromion. I take full control of the arm and you tell me if it hurts, and he's starting to get a bit of pain there. The Hawkins test or internal impingement sign I will perform as well, so pushing your arm up against me. Now this is a little tricky because a number of other factors may cause pain in this area. The posterior rotator cuff, infraspinatus and bursa may impinge. Compressing the acromioclavicular joint may reproduce pain. An irritable long head of biceps, possibly with his subscapularis deficiency as well, what we sometimes call internal impingement. To assess the acromioclavicular joint further, the one test that's helpful is an overpressure test, and at this stage he's quite comfortable with that. Following this position, while the patient is seated, I do one extra test, which I call the external rotation overpressure test. You recall that the patient had a limitation of external rotation, so his normal side went to 80 degrees, his painful side went only to 30, and I take him to that point and then I jerk the arm and he grimaces a little. This is not an impingement test, although with severe bursitis some patients have pain. It tends to create a reaction and pain with adhesive capsulitis. There's also the concept when you're doing this test of the end feel, and many of you are familiar with this. Patients that have osteoarthritis have a very hard end feel. As I explained to patients, we take it to a point and it's like we're hitting a brick wall. With adhesive capsulitis, it's not as rigid, but it's certainly very irritable. And it's a good predictor if the anterior structures, so predominantly the middle glenohumeral ligament, is becoming restricted and tight as you rotate them. And many of these patients are unable to go into abduction and external rotation. From here, I'll be moving now into strength testing. Moving on to strength testing, it's really important to avoid pain when we test the patient's strength. So we're not looking at doing any testing in impingement type or known painful positions. So I would start by looking at rotatory strength with the patient's elbows by their sides. Pushing in against me, that's good, and pushing out against me. A little bit of weakness on his external rotation on that side. From here, we would look at doing elevation, starting quite low, pushing up against me, and again in this position, pushing up against me, and there's slight irritability there. Now, the empty can test involves the patient being more elevated and abducted. It's a fairly aggressive test. It's been used to look at rotator cuff integrity, but it can be confused very much with severe impingement. So I'm careful with that. If you flare your patients up fairly early in the examination, it's going to interfere with your ongoing examination because of the muscle spasm they'll have with that. Now, the other thing I'm going to mention is looking at strength through range, so a bit more functional testing. So for someone who is a swimmer, who does a racket sport where they need to perform overhead movements, I'll move on and do further testing in abduction, pushing up against me. Then at 90 degrees, externally rotating, pushing up and pushing down. Then take them to as much external rotation as they are, pushing back, pushing forward, and then the same thing in the elevated position, pushing back and pushing forward. Now, a quick word on the relevance of weakness. In an intra-office setting, if you can find through your own palpation a side-to-side difference, that would be consistent to at least 15% reduction if you're performing isokinetic tests or using a dynamometer of some description. And it is helpful to have numerical values. Patients love it, particularly if they're looking at rehabilitation and improving. The other thing that's important about the functional testing is when you're looking at returning to the overhead sports I've mentioned, such as freestyle swimming, tennis, golf in a dominant arm, throwing, you need to complete your rehab in the position of abduction, external rotation, and overhead. We're going to now do some more extensive testing and a couple of other special tests. This final part of the physical examination is with the patient lying down. This topic of the stiffening, painful shoulder, you'll notice that I haven't alluded to instability of the glenohumeral joint or labral pathology. We've left that for another time. So what do I do with the patient lying flat? First of all, when the arm is low, that is to the side, there is no impingement occurring. So I like to initiate elevation with a test that I call the lift up test. And quite simply, the patient has their thumb and forearm in a neutral position, and I ask them to initiate elevation off the bed. So lifting up against me, I compare it to the other side, lifting up, and there's a big difference in strength again. And patients sense that. They're actually quite surprised they have that difficulty. This would suggest that the supraspinatus insertion is not secure. There may be a degenerative tear and associated with some of his impingement features. The thing you notice as well, and even in full thickness rotator cuff tears, if you have the patient at 90 degrees and ask them to push against you, they're quite strong with a deltoid that's quite active and powerful. The other thing I do in this position is recheck the humeral head positioning. Patients who have a large torso and trunk, often when they're lying down, their humeral head is quite anteriorly translated. So I'll elevate the elbow. So basically the humerus is parallel to the spine, and then I'll take external rotation, and once again, he's still irritated and restricted there. So in summary, let me just go through the main features that we found. So in summary, let's go through what we found with our patient with Richmond, who actually has a good shoulder but helped us out today. He had limitation of active motion in terms of elevation, external rotation and internal rotation. He had weakness on a lift-off test and an initiating elevation as well, and he had some impingement signs. He'd had previous surgery. So clinically, he presents as someone with rotator cuff deficiency, partial tearing, maybe full thickness, but more likely partial, of supraspinatus and subscapularis, with some early capsular features as well. A little young for that, but not unusual. So let's summarise our main findings, and once again, I hope you found this helpful. Take a holistic view of the patient. View them as a whole in terms of their past history with sport and exercise, their work, and what their expectations are. Look at their metabolic health and a history of inflammatory or arthritic disorders, highly relevant when inflammation is part of the profile. When assessing and looking at diagnosis, it's important to do side-to-side testing, and differences in active range of motion, passive motion, power, and end feel are all critical, and the patient picks up on that as well. For patients under 40, the frequent diagnoses are shoulder impingement, acromioclavicular joint synovitis, and both of those may exist with long head of biceps tendinopathy. With patients over 40, those diagnoses may occur, but in addition to that, we'll have more extensive impingement, possibly with rotator cuff tearing, adhesive capsulitis, particularly in females, and glenohumeral osteoarthritis, particularly if there's a history of trauma. Don't forget calcific tendinitis may occur, and as a reminder, again and again and again, because I've seen people caught out, X-ray your patients who have a stiffening, painful shoulder. Thank you.
Well, thanks, John. That was both an entertaining and an informative talk. And I certainly picked up a few things. I don't know about you, Daron.
Oh, absolutely. There was a lot of really great information there. I guess one of the things that I like best as a surgeon is the fact that John really referred to getting an X-ray done on pretty much every single patient.
Yeah, you'll be happy if the conversation is just centered around bones, really, wouldn't you?
No, look, what happens typically once every 2 years or so, a patient's had 7 or 8 weeks of treatment and they get to me and I do an X-ray and it turns out they've got something like a bone tumour which needs treatment. So I think the fact that we're getting an X-ray on each person is actually really important.
Well, you know, all jokes aside, it actually is not that well understood. Everybody will assume that an MRI, given, I guess, how fancy it is and expensive it is always going to be the superior investigation. And quite simply, it's not always the case. I don't know if you've got any particular cases that you've had, John, where you've actually had an X-ray absolutely change the diagnosis.
Look, I have, Paul, and the big one really, which is in the handout, is calcific tendinitis, which doesn't always show up well on an MRI scan, but that is a cause of acute shoulder pain, acute impingement, and a shoulder that may be stiffening. The other thing we find is that patients that have impingement, they may come to us and they've had an ultrasound which shows thickening or impingement of the bursa with or without rotator cuff pathology. But those patients may have acromioclavicular or glenohumeral osteoarthritis. So they're both not uncommon scenarios. And they're not very happy patients, I've got to tell you, when you send them downstairs for an X-ray and you change the diagnosis and they've had 4 to 6 months of treatment for something else. So For our physiotherapy audience, a plain film is something you can arrange. Just ask for a full series of the shoulder and AC joint, particularly if they're tender over it, and it will clarify the diagnosis and exclude some other pathologies, as you mentioned, are on sinister pathologies. That would be my suggestion there.
Okay, and you're also known as a bit of a doyen of the shoulder. So, and you have mentioned the AC joint, and in my experience, the presentation of the AC joint can be very protean. It can present in a number of different ways. I don't know if you've got any little clinical pearls that you'd be able to share with how to actually approach the AC joint.
Look, thanks, Paul. I think you flattered me there, but as far as the AC joint's concerned, and let's exclude traumatic separation of the AC joint, where you've got a real anatomical change. Let's talk about synovitis and osteoarthritis with the AC joint. Its anatomy is fairly broad. It's a broad joint. Where people experience pain can vary. There's often a lot of trapeziospasm with it. And so really you've got to be clear on your anatomical landmarks with palpation, and also appreciate the fact that at end range of motion, it tends to get compressed and sore. So we always do an adduction test, but I've found that the end range of internal rotation can irritate an AC joint, and it's helpful to palpate it in that position, and also the end range of elevation. So when you're doing those movements with patients, I found, I don't know about you, Doron, but I've certainly found that getting them to point to where it hurts when they're in that position is helpful.
Oh, I agree completely. And the really nice thing about the AC joint, John, is as you know, you can just inject it easily in room. It doesn't need to be done under ultrasound, and you'll know within 2 or 3 minutes of the injection whether that was the source of the pain or not. And it's quite amazing how patients come in complaining of terrible pain. You give them the injection, and all of a sudden, their arm's easily above their head, as it wasn't for a long time beforehand.
And Doron, in your experience, that's not necessarily just for pain that's localized to the AC joint, because as we all know here, it can actually refer relatively widely. It's got quite a disparate innervation.
It is, and a lot of people present with either anterior or posterior shoulder pain, where in fact the AC joint is the source. So I think it's one of the most commonly missed diagnoses is AC joint arthritis or arthrosis.
And the in-rooms injection is an easy way to diagnose that.
Absolutely it is. Yeah, it can confirm the diagnosis for you, but I guess it's like with most things, if you don't look for it, you don't see it. And unfortunately, a lot of people don't necessarily specifically examine for the AC joint. It's a little bit like the biceps tendon as well. It's a large source of pain in the shoulder, and if diagnosed properly, can be change your treatment plan completely.
Well, a thoroughly entertaining lecture. So thank you on behalf of everybody, John. I go away a little bit wiser.
Well, good morning once more. It's good to be back with you. My name is Doron Scher. I'm an orthopaedic surgeon, and I'm going to be talking to you about meniscal root repairs today. A little bit of basic anatomy. The menisci are found on top of the tibia, and they make the tibia from being a flat structure to a curved structure to match the anatomy of the femur. They are shock absorbers, distribute loads, they provide nutrition to the articular cartilage and proprioception to the knee. If we look more closely at a cross-section through a knee, we see you have the bone, then you have the articular cartilage, and matching perfectly in between the articular cartilage surfaces is the meniscus. If we now look at the blood supply of the meniscus, the peripheral or vascular zone has a thicker convex shape, whereas the central avascular zone, which is otherwise called the white zone, has a more concave superior surface conforming to the femoral condyle. Now, the flat inferior surface of the avascular zone allows for optimal adherence to the tibial plateau. The blood supply comes in from the periphery and then peters out, and this is why if you have an injury in that red zone, it's more likely to heal than if the injury is in the red-white or white zone. These images are taken as if you were looking down on your own knee, and it can be a bit confusing, being a left knee with a medial, a right knee with the medial meniscus on the left-hand side of the picture and the lateral meniscus on the right-hand side of the picture. The medial meniscus posterior root attachment is 9.6 millimeters posterior and 0.7 millimeters lateral to the medial tibial eminence, and that's the most reproducible osseous landmark in the knee. If you look at anteriorly, the medial meniscus anterior root attachment inserts along the anterior intercondylar crest of the anterior slope of the tibia. Now, turning this around to see what you're used to looking at when you're looking at the patient, you can see the image on the left is a right knee with the just a sketch of it. On the right side, there is an actual cadaver, and you'll see over here where these two stars are. That's where you want the drill holes to exit if you're going to do a meniscal root repair. But we'll talk more about this a little bit later. Within the menisci, they are mainly type 1 collagen fibers, and they are the primary providers of the tensile strength of the meniscus. They are arranged circumferentially as well as radially, as well as having a mesh network of fibers. So the extracellular matrix is made up mainly of water, with about 20% of it collagen, glycoproteins, proteoglycans, and non-collagenous proteins. As you get vertical force applied to the meniscus, it turns it into a more circumferential force, with the hoop stresses being distributed more evenly and protecting the articular cartilage from chondral wear. When we look at the motion of the menisci, in extension they glide anteriorly, and in flexion they glide posteriorly. And if you lose your meniscal root tear, there can be a lot more translation and a lot more stress in the peak contact pressure between the articular cartilage surfaces. So in extension, about 50% of the compressive load is transmitted through the meniscus, whereas in knee flexion, 85% of the compressive load is transmitted through the meniscus. And so we see in a diagram where there are normal hoop stresses over here, and we get even pressure through the menisci and articular cartilage. If we happen to have a tear of the meniscus as seen in this back corner, all the pressure goes onto the articular cartilage, and you can understand why that would start to deteriorate. Now, if we talk about meniscal injury classification, there are multiple different ways to think of it, and I think all of you will have seen this classic diagram showing the different type of meniscal tears. But the one type that this really doesn't look at is this type over here, where it tears right at the meniscal attachment. So a meniscal root tear is defined as a radial tear located within 1 centimeter from the medial meniscal attachment or a bony root avulsion. For this talk, I'm going to focus on medial tears, but they can occur on the lateral side as well. This is mostly associated with ACL injuries, so most of these patients are going to have an operation anyway. So the overall incidence of these tears is quite low. It's about 10% of all arthroscopic meniscectomies. And as I said, where the transmission of the circumferential hoop stress is impaired, which alters the biomechanics and kinematics. So just to remind you, the root attachment site for the medial meniscus is identified that 9 to 9.6 millimeters posterior and lateral to that medial tibial eminence apex, which is that bony landmark, and Dr. LaPrade has classified these into 5 tear types. Type 2 is subclassified into A, B, and C, and since these tears are increasingly being recognized as a cause of morbidity and the development of early OA, it's more important to understand when they're there and when they can be repaired. So the medial meniscus posterior root tears are commonly degenerative and seen in middle-aged women, and that may represent up to 20% of the posterior horn medial meniscal tears. So just going through them, the type 1 is a partial stable root tear. This is about 7% of the root tears, and it's within 9 millimeters of the center. And we're going to go through the MRI findings, which we see just this little white line showing the tear. The type 2 tears are the most common, nearly 70%, with the 2A, B, and C indicating whether it's 0 to 3, 3 to 6, or 6 to 9 millimeters from the root attachment. Type 3 tears are typically bucket handle tears, and you can see the tear extending here further back into the meniscus itself, and this is about 6% of root tears. Type 4 tears are the complex oblique tears and are about 10% of tears. And then there are the bony avulsions, which are much more rare and usually associated with other trauma to the knee. Now, there are two general age groups. Again, we're going to focus on the older age group, which is the over 40 age group, acute onset but only relatively minor trauma, a minor squat, standing up for a chair, walking stairs, as distinct from the younger age group, which is usually associated with something like athletic activity and perhaps an ACL injury. So the history of a medial root tear is the same pretty much as any other meniscal tear. It's fairly abrupt onset, it's often more severe pain than what you would expect in these patients, and at least 70% of them are seen in degenerative knees. The other factor to look at is the diagnosis of spontaneous osteonecrosis, or SONC. Now, the risk factors for the root tears are varus alignment, increased age, higher body mass index, and female sex, and these have always been known as the risk factors for SONC. And it turns out that perhaps spontaneous osteonecrosis was just a missed diagnosis of a meniscal root tear, with increased stresses being placed on the bone, leading to the edema and stress fractures. Now, these patients may or may not hear a popping sound and may or may not present with specific joint margin tenderness when you see them. So the clinical examination is quite difficult to distinguish from any other type of meniscal tear, with joint line pain, effusion, and loss of flexion. Of course, you might get a positive McMurray's and Thessaly's test as well, although there probably won't be the mechanical click that McMurray described. Are there any objective signs? Well, there was one paper showing full extension and varus stress created pain, but this hasn't really been reproduced by other people. The root tear can result in an extruded meniscus, which is palpable along the anteromedial joint line with that various stress, and this extrusion disappears when normal knee alignment is restored. What about imaging? Does this help us? Well, if the imaging is normal, it doesn't really help us, but you must get a flexion weight-bearing X-ray looking for increased arthritis. The other thing that's very helpful is a standing or full-length weight-bearing film to work out your degree of varus or valgus, and an MRI is the key for us when we're looking for articular cartilage damage and an actual meniscal tear. So studies on MRI sensitivity and specificity rely on 3T MRI and fine slices being done. If you're on an older scanner with thicker slices, probably you're going to miss the diagnosis. Now, if you look at these numbers, essentially it's good to rule it out, but not great to rule it in. What that means is if the test doesn't show you the condition, you are very unlikely to have the condition. But if the test shows the condition, it doesn't necessarily mean that you have the condition, or well, you're 70% likely to anyway. So on the MRI, you're going to use two T2 weighted sequences and look at both the coronal, sagittal, and axial sequences. And what you're looking for are these things: a linear high signal intensity perpendicular to the meniscus at the meniscal root in the axial plane, and I'll show you that in a minute. The vertical linear defect, otherwise known as the truncation sign, and then the ghost sign with absence of the meniscus. So on this particular MRI, you see the posterior root avulsion and the gap between the meniscus and the root, and here you see the medial meniscus extruded beyond the tibial margin. So extrusion is considered pathological if it's more than 3 millimeters, and it's most clearly identified when using 2 consecutive slices on the MRI, and this will be found in nearly 2/3 of cases. And here's a clinical image showing a diagram showing it, and then the actual MRI showing the same thing. Once you have meniscal extrusion, clinical studies have shown a very high incidence of medial joint surface chondral damage in the order of 70 to 90% on arthroscopic examination. So if we have a look at the type images on the axial, the coronal, and the sagittal signs, you see the partial tear where the arrows are. If we then go to type 2, you see the more complete radial linear defect. You see the fluid cleft sign, and then you see the absence of the meniscus or the ghost sign. And just reminding you that the type 2 are subdivided into the distance of the complete discontinuity of the meniscal root, and here we have an arthroscopic image with a grabber holding the meniscus which doesn't attach onto anything at the root tear. Vertical longitudinal bucket handle tears again are seen by the complex nature on the MRI, and you can see the root here and the bucket handle going all the way around there with the femur and tibia on these images. Once again, we look at the axial, coronal and sagittal images to see the tear for the type 4 tear. So this is an MRI scan video showing the various features. This is the femur over here, the tibia down the bottom, and we're looking at the posterior cruciate ligament on this slice and absence of the meniscus there with a ghost sign on that sagittal image. Looking at this is where you should see a dark triangle in that area over there. As we go further medial, you start to see the meniscus, and that's what it's supposed to look like all the way out towards the PCL. You see the increased edema or white area in the tibia, fluid and damage to the joint margin with the articular cartilage, and more normal looking bone on the femoral side of things. On this MRI, we're starting to see meniscal extrusion, as well as seeing that increased bone edema in the tibia. And at this point here, you should see meniscus going down and attaching onto the tibia, which it clearly is not. The rest of the meniscus doesn't look too bad, although there is some signal change within it. And once again, we see the tibial bone edema and the absence here. Going through the coronal slices, we look at the lateral meniscus, the medial meniscus, and that fluid gap cleft sign at the back with the radial linear defect. All right, so are there any patients not suitable for any type of arthroscopic surgery in this case? Well, clearly the answer is yes. If they're elderly, if they don't have much in the way of symptoms, and particularly if they're not going to be able to tolerate the rehabilitation after the surgery. So if they've got fairly advanced arthritis, they're not going to get surgery. So what do we do with these people? Well, assuming they're not suitable for surgery, you're going to modify their activity, perhaps give them some anti-inflammatory tablets, some physiotherapy strengthening exercises, and some basic biomechanical modalities as well. What about surgical treatment? Well, surgical treatment is broadly divided into providing symptom relief in the short term versus correcting the biomechanics of the knee. And while surgical repair isn't indicated for people with more diffuse advanced arthritis, if the person has isolated articular cartilage injury, you may still go ahead with the surgery. So a total or partial meniscectomy was something that was performed in the past, and it definitely works well and gives the person a year or two of relief, but unfortunately then leads to more rapid onset of arthritis of the knee. Since the goal of surgical repair is to restore the joint contact pressures and kinematics and therefore delay the arthritis, repair is a very reasonable option in patients that can tolerate the rehab. All right, so who is a suitable patient? Well, you want someone under 65 years of age preferentially. You don't want them to have a lot of varus, and you want them to have mild arthritis with mild subluxation. What this means is that it's only about 20% of all root tears. So you've got an acute meniscal root tear, you must repair it. If you've got a chronic and they've got minor chondral lesions, you're going to treat them differently if they've got more advanced chondral lesions. The minor chondral lesions will get repaired, and the more significant chondral lesions will either have a partial meniscectomy or no surgical treatment at all. So who shouldn't get it? Well, basically the reverse of what we said. More than 65 years old, unable to tolerate the rehabilitation, varus or advanced arthritis. And it's not good enough to get a standard weight-bearing view, which you see here, because on the flexion weight-bearing view, they might have more advanced arthritis visible. And this is probably 80% of all root tears that don't get surgery. So this is a diagram showing what's actually done with the drill holes going into the tibia and the sutures being tied over a button or post or fixed with an anchor on the anterior tibia. So there's that root attachment, there's those drill holes coming and exiting on the anterior tibia. Here's a couple of intraoperative photographs where you've seen the articular cartilage cleared with a drill hole coming out here and a suture passing device passing the stitch into the meniscus with the femur on top, the tibia down the bottom, and the meniscus on either side of it. So this is a cadaveric video showing you the operation. This is the femur up the top here, the tibia down the bottom. This is the medial meniscus, the tibial condyle. The articular cartilage has been cleared on the tibia, and we can see the guide being brought in now. And it's very important that this drill hole is made accurately. Ideally, we try to put two tunnels adjacent to each other and two sutures so that we can pull the meniscus down onto the bone and get healing in that area. And obviously by drilling holes in the area, we get a blood supply coming in. So this is a probe touching that root tear or that free end of the meniscus, which should be attached onto bone. And there you see the drill coming up into the tibia, and we'll leave a tube inside there to allow suture passage later. Here's one of many suture passing devices going into the knee, and you can see the blue and white thread which will be passed into the meniscus itself, and we want to get a good bite of this really solid tissue so we can pull hard on it without it coming out. Once we've passed that suture with that needle punching through there, we then the suture is grabbed automatically by that device and it's pulled out through the front portal of the knee. And then we have to be careful not to get our sutures crossed, so we might use a passing cannula to pass now a grabbing instrument. We pass a loop up that tibial tunnel, grab the loop with our passing instrument. We make sure that it's not caught on anything along the way, pull it out through the front of the knee. We pull that blue and white suture into that black loop, which then pulls it down into the tibial tunnel. Now we're going to repeat that same process to be able to get two stitches into the meniscus and then pass them through. So this operation, in fact, doesn't take a huge amount of time, but it is technically challenging because you're working in a relatively tight space, and you have to be careful not to damage the articular cartilage, which is immediately adjacent to where you are. And these days we have beautiful kits specifically designed to do it. So here we are with a second suture being pulled down into the tibia, and momentarily we'll see both of them pulled on, and that'll pull that meniscus down onto the bone. And now we can see that that root has been reattached onto the bone to restore the circumferential stresses which are present and to stop the meniscus extruding. Then we tie it one of many ways onto the front of the tibia using a relatively small cut. So what about post-operatively? Well, we tie the sutures with the knee at 90 degrees to make sure that we can do at least 0 to 90 degrees in the first 2 weeks without loosening the sutures. The rehab protocol is very specific, and it really does need to be adhered to, because if the person walks on the knee too soon, they're going to loosen those sutures and the repair won't work. So it's non-weight bearing for 6 weeks, partial weight bearing for 6 weeks, and you do 0 to 90 for the first 2 weeks only. We don't really like them axial loading at flexion of more than 90 degrees until after 6 months while we wait for it to heal. What are the other options? Well, you can use an unloaded brace if the person's got slight varus, and you also don't want them doing any cross-legged sitting or deep squats, anything else which is going to put a lot of pressure on the meniscus. It's about 5 to 7 months before they resume impact activities, but in this older age group, not a lot of them do that sort of activity anyway. Outcome studies are very varied. It does seem that the newer and more robust tibial tunnel technique is better and giving better results than the old intra-articular suture anchor techniques. So I'm going to run through a couple of case studies. We've got a 59-year-old manual worker, chronic posteromedial left knee pain without a clear history of injury. His examination showed posteromedial joint margin tenderness and a stable knee. These are his x-rays, mild medial joint margin narrowing. However, when we get the Rosenberg views, we see that he's pretty much bone on bone on the medial side. This automatically makes him unsuitable for repair, even though on the MRI scan we see a meniscus root tear with extrusion, and he's got full thickness chondral loss in his knee. So his treatment is the basic treatment for osteoarthritis, non-steroidals, injections, activity modification, and he did very well with non-operative treatment. Now he will deteriorate and require arthroplasty at some stage, but that's inevitable. The next case, 48-year-old plumber, 3 months of worsening knee pain, and began while running on a treadmill. Now the pain has been medial-sided ever since, and he has had trouble with stairs and squatting as a plumber. He's been given physiotherapy and injections and didn't get any better. His examination again showed medial joint margin tenderness because there really aren't any significant clinical signs that are different for a root tear. X-ray showed grade 2 arthritis, and an MRI showed his root tear with 4 millimeters of meniscal extrusion, and his tibiofemoral cartilage was thinned. So if we have a look at his intraoperative pictures, he was consented for a root tear or meniscectomy, and because of the extent of his arthritis, he just had a meniscectomy. Now this worked very well for about 18 months, but over that time, as expected, his varus increased, his arthritis increased, and eventually he came back for treatment for a high tibial osteotomy because his lateral compartment was still good and he was a young, active man. Now again, eventually he'll come to a knee replacement. What about study 3? 47-year-old female office worker. She stepped in a pothole 10 months ago with quite significant posteromedial pain. A corticosteroid injection did give her some relief, but not for very long, and she's tried all the usual treatment modalities which haven't helped her. Her examination again showed the same thing with posteromedial joint margin tenderness. Her x-rays were normal, and her MRI, as you see on these pictures, showed a medial meniscal root tear with the classic 4 signs. So her treatment was a transtibial root repair. She followed the post-operative protocols nicely with 6 weeks of non-weight bearing, 6 weeks of partial weight bearing, and no axial loading greater than 90 degrees until after 6 months. And she has done very nicely with an essentially normal knee at 2 years. So, in summary, meniscal root tears are more common than we realized. Having said that, only about 20% of them are going to need surgery, and the rehabilitation is quite challenging for older and overweight patients. But repairing the root does restore meniscal function if it's done properly. So if you have a patient that you suspect may have this diagnosis, don't hold on to them for too long. Either get a high-resolution fine-cut MRI scan and let the radiologist know you're looking for this diagnosis, or send the patient along for assessment, and you may end up saving them an early knee replacement. Thank you for your attention, and we'll move on to our next lecture now.
Well, Dron, that was another very strong lecture. Excellent pictures, excellent descriptions, and very informative. John, I don't know if there's anything in that lecture that really struck you?
I learned a number of new things. I've been trying to sort of watch this space of meniscal root for a little while, being aware of some discussion, but what I appreciated was some of the reminders of the role of the meniscus, so nourishment of articular cartilage, stability, but its association, root tears, with articular damage, osteonecrosis, osteoarthritis. I think, Daron, that was very, very helpful and very important. I'd like to hear from you, I guess, clinically. Is there anything that we can pick up that's different, or do we rely primarily on the MRI and aspects of the MRI?
So the clinical examination is kind of tough because it's not that different examining any acute meniscal tear or any, your McMurray's test, your Thessaly's test. That one paper which showed full extension varus causing some extrusion hasn't been reproduced by other people. Where I do think there is some differentiation is on the history. There are some people that just seem to have a lot more pain than what other people do when they present after their meniscal tear. They're the ones that come in hobbling on the crutches or getting pushed in a wheelchair when all you really see is very mild arthritis It just, things are way beyond what you would expect them to be for the pathology that they have. And these are the people you need to start looking much more closely for the meniscal root tear. In your mind, you need to be thinking about it, and then you need to be investigating them appropriately, rather than punishing them with 4 or 6 weeks of treatment before investigating them.
I think also the consequences of missing and not managing it, really now with really good quality MRIs, it can be a real game changer if you can pick it up and treat it in terms of the prognosis and function of the knee joint.
Look, and unfortunately, amongst that age group, you're still probably only going to get to treat 20% of the people that you make the diagnosis in. But for those 20%, it's going to be a life-changing event for them, and perhaps stop them from having an early knee replacement.
And I think if perhaps anybody's ever in doubt of the importance of the function of the meniscus in the knee, and have no doubt that a root tear basically defunctions a meniscus. I recall early in my career, when I used to be a physiotherapist with the military, having some patients that had total meniscectomies. It used to be a standard procedure that if you had ever had clicking or any internal derangement in your knee, they said, no worries, you can join the military. We're just going to take those pesky cartilages out of your knee, those cartilages being the menisci. And I have never seen more deformed knees early on in any patients, except those patients who had their meniscus taken out. They truly are an essential component to the knee. And if they're not functioning well, the knee degrades like no one's business.
Yeah, not only that, Paul, but the other issue with them is that most people don't think of them as stabilizers of the knee. But I've seen a number of patients over the years that have torn their ACL, but their menisci have been intact. And because the menisci act as secondary stabilizers, the knee can remain stable. It's not until something happens that they then twist again and tear the meniscus that all of a sudden, years later sometimes, they get the sensation of instability in the knee, despite the fact that they haven't had an ACL for a very long time.
Do you think it goes the other way as well, that if you've got a defunctioned meniscus, that then leads to extra stress on the cruciate ligaments and potentially degenerates? Because we often see myxoid degeneration and certain degenerative changes in the cruciates that are quite poorly defined in terms of their pathoetiology.
Yeah, that's true. I mean, the problem, I guess, to some extent with that is if you're already starting to get some medial compartment arthritis, part of that process is somewhat translation and rotation, which does cause deterioration of the ACL at the same time. And it's kind of the chicken and the egg, which came first. That's very, very hard to know. But even a lateral meniscal tear. So if you guys have seen those patients where they have a really gross grade 3 pivot associated with their ACL tear, but nothing else seems to be damaged. They haven't had any other major disruption or posterior capsule or anything like that. And often those are the people that have that lateral posterior root tear. But that's a different age group. That's that sort of under 40 age group rather than the over 40 age group with the medial sided tear predominantly.
I think we need to remember too that with meniscal tears, often you get a proprioceptive change, and that would be a risk for instability of the knee, certainly in a high demand athlete.
It gives me great pleasure to introduce Dr. Jerome Goldberg. Jerome has retired from surgical practice, but is still sharing the benefit of his wisdom with us. He was my mentor, taught me most of what I know about shoulder surgery. And as usual, we're looking forward to a fantastic talk from Jerome.
I'd like to welcome you all to this webinar on the management of the first-time dislocator. Shoulder dislocations are very common. The main problem with these dislocations, especially in young patients, is the very high incidence of recurrence. As you can see from these papers, which we've extracted from the literature, especially in the younger patient and especially in male patients, the risk of recurrence is up to 90%. Glenohumeral dislocations are associated with labral tears, capsular damage, articular cartilage and bone damage, and rarely nerve and rotator cuff damage. There is a much higher instance of developing osteoarthritis later in life if you've had a dislocation. The traditional teaching has been that a patient needs to have 3 or more dislocations in a short period of time to merit operative intervention, but that's all changing. What we were taught when we were younger is we put the patients in a sling for 3 to 6 weeks, and though evidence shows it makes no difference, they embark on a course of physiotherapy, and once their strength has returned, they go back to full activity. If they have recurrences, then surgery is indicated. The real problem with that paradigm is that with each dislocation you get further joint damage and a much higher risk of developing osteoarthritis in the future. It's worth briefly mentioning that if you are going to embark on non-operative treatment, then you're far better off using an external rotation brace rather than a sling where the arm sits internally rotated. And that's because external rotation better approximates the labral tear to the glenoid. You have a look at these photographs. On this side, on the left side, you see someone in internal rotation in a sling, and you can see the labrum there is a long way from the glenoid and almost certainly won't heal. When you put the patient in external rotation, the labrum approximates the edge of the glenoid, and there is a reasonable chance that you might get healing. It's been shown, especially by Ito, that the recurrence rate of someone in an external rotation brace is far less than those held in internal rotation, but the follow-up was too short and approximated 12 months. So what are our alternatives? Traditional sling followed by physiotherapy, an external rotation brace which may or may not work, arthroscopic lavage, which some people have used in the past, it's never used anymore, a capsular shrinkage where you electrically shrink the capsule by burning it. That's been shown not to work, and there are many complications associated with that. And the 2 surgical procedures, either an arthroscopic stabilisation or an open stabilisation with or without a bony transfer, are options that are available to the as the editor of Shoulder Arthroscopy said some years ago, historians will likely view our past treatment of traumatic shoulder dislocations as suboptimal. Orthopaedic surgeons operate on acute ligament injuries of other joints, but rarely on the shoulder. So what is our aim here? Our aim is to ensure long-term stability to the shoulder, and more particularly to avoid further damage to the joint. There was a large study in Scandinavia done by Hevelius some years ago with a 25-year follow-up of a large number of shoulders. He found that 56% of these patients had osteoarthritis, and 39% of recurrent dislocators who had not had surgery developed arthritis on X-ray, whereas 26% of recurrent dislocators who had surgery had osteoarthritis, but the amount of osteoarthritis in this cohort of patients on X-ray was far less than those who hadn't had surgery. And it was clear from this study that there was a higher incidence of osteoarthritis in recurrent as opposed to single dislocators. If you have a look at this video, it's an arthroscopic video of a patient who had a single dislocation. You can see the articular cartilage damage. The humeral head's on the right, the glenoid's on the left. It's a very telling video. So what are the advantages of an early shoulder stabilisation? Well, you reduce the risk of recurrence, you reduce the joint damage, you address the pathology, and theoretically, if you do the surgery within 6 weeks of their first dislocation, the healing potential is at its maximum. All the healing cells which come out with the bleeding are there for about 6 weeks, and the labrum is more likely to heal to the glenoid. So the recurrence rate in first-time dislocators, as we've mentioned, is fairly high, and these are studies in the recent literature that have compared groups of patients who had non-operative management and they had high risks of recurrence compared to those who had surgery after the first dislocation. And you can see here that the recurrence rate reduced dramatically. Jacobson from Scandinavia also found that those patients at 10 years who had non-operative therapy, about 3/4 of them were dissatisfied, whereas those who had had repairs, 3/4 of them were satisfied. So which are the high-risk patients? Anyone under 25 to 30 years. Males are more susceptible to damage and to recurrence than females, and those involved in contact sports, surfing and overhead sports. And these are the groups of patients that we need to seriously think about considering operative management after one dislocation. So if we have a look at the high-risk pathology, you can see in this slide a tear of the labrum here. That's the humeral head, that's the glenoid, and I've got a probe around the labrum and it's come off the glenoid. You can see the blood there from the acute dislocation. This picture is of the back of the humeral head, and this is what's known as an impression fracture or a Hill-Sachs lesion, and those patients who have large Hill-Sachs lesions are more prone to recurrence of dislocation. Patients also get bony damage and lose some bone of the anteroinferior part of the glenoid, and if that happens, your risk of recurrence is higher. And very occasionally some patients tear the humeral part of the glenohumeral ligament, and that's called a Hagel or humeral avulsion of the glenohumeral ligament, and if that occurs, the risk of recurrence is fairly high. So my approach to these patients is I get a history, I try to find out whether this is a traumatic or atraumatic dislocation, the extent of the trauma, the patient's activity level, whether they're hypermobile, and it's important to perform an anterior apprehension or anterior relocation test as seen here. Try not to dislocate their shoulders when you do that. And it's important to get a number of investigations. Clearly, the first investigation is a plain X-ray. You can see down here, this patient has a bony Bankart lesion, or they've detached part of the anteroinferior glenoid with the labrum. And you can see here a Hill-Sachs lesion, which is a lesion or an impression fracture of the posterolateral corner of the humeral head. I then get an MRI. If they've had the dislocation within 48 hours, there's enough blood in the joint from bleeding to create a contrast agent. But if it's over 48 hours, I like to have an intra-articular injection of gadolinium performed so I can have a look with far greater accuracy at the extent of the labral damage. And you can see here there's a tear of the anteroinferior glenoid. The contrast is leaking around the torn labrum here and here, and you can see the start of a small Hill-Sachs lesion. If I have a patient who has bony damage, then I always get a CT scan, usually a 3D CT, and here you can see a large bony Bankart lesion where a significant amount of the glenoid has detached with the labrum at the time of the dislocation. If there is bony damage, it's important to determine how much bony damage there is, because it does influence the type of procedure you're going to do. Essentially, we need to find out whether there's damage just to the glenoid, just to the humeral head, or to both. Hence the term unipolar and bipolar. If there is only damage to one side of the joint, it's unipolar damage. If there's damage to both sides of the joint, it's bipolar damage. You assess the amount of loss of glenoid articular surface, and if it's less than 20%, as indicated by this red line here, that's an important parameter. And you assess the extent of the Hill-Sachs lesion by comparing the diameter. And the bottom line is, if you just have damage to the glenoid and it's less than 20%, you could potentially do an arthroscopic procedure. If it's greater than 20%, they need a bony procedure, such as a Latarjet procedure, which we'll discuss a bit later on. If it's unipolar and only involves the humeral head, and it's less than 40% of the diameter, you can often get away without bony surgery. But if it's greater than 40%, then you do need to consider bony surgery. A much easier way is to use a system of on-track and off-track, and I know this is all a bit complicated, but essentially by getting a CT scan of the shoulder, you can actually work out mathematically whether the shoulder is going to remain on track and therefore not dislocate, or off track and dislocate due to the Hill-Sachs lesion and the glenoid bony Bankart lesion. And if it is an off-track lesion, you need to consider bony surgery. So what is my protocol? Well, if I look at patients who are in a high-risk group, who are under 30 years of age and have had a single dislocation, once I've done my history and physical examination and I've reviewed the radiological investigations, I make a decision. If they have an isolated labral tear on the MR arthrogram, I offer them an arthroscopic stabilization, and I usually combine that with a posterior capsular plication, and I close the rotator interval in contact athletes. If they have a Hagel or humeral avulsion of the glenohumeral ligament on MR arthrogram, I would recommend an open stabilization rather than an arthroscopic procedure. And the reason for that is to get down to the inferior part of the capsule arthroscopically, you can catch the axillary nerve with your sutures, because you're doing it from inside out. Whereas with an open shoulder stabilization, you're doing it from outside in, and you're viewing directly the axillary nerve. So there is a much higher incidence of an axillary nerve palsy if you do an arthroscopic procedure on a Hagel lesion, and an axillary nerve palsy can be absolutely devastating to the patient. It's usually permanent. If that patient, even in a high-risk group under 30, has a normal MR arthrogram, then I would consider non-operative treatment, which we'll discuss in a moment. If they have a small bony Bankart lesion and a Hill-Sachs lesion, and they are on track, I will do an arthroscopic stabilisation plus a remplissage, which we will discuss in a moment, in the non-contact athlete, but I would favour an open stabilisation in the contact athlete. If they have a large bony defect and or a Hill-Sachs lesion, that is, they have unipolar or bipolar bony deficiency, and it's an off-track lesion, then I would recommend Latarjet or a coracoid transfer. How do we do an arthroscopic stabilisation? We put the telescope or arthroscope into the joint and we fix up any of the pathology that we see. We do a labral repair where we reattach the labrum back to the glenoid using some anchors with sutures attached and tie the labrum down to ensure that there's healing to the bone. If the capsule has been stretched or if the patient has a hypermobile shoulder, we tighten the capsule at the back. And a remplissage procedure is to put some anchors and sutures into the small Hill-Sachs lesion and pull the infraspinatus into that lesion and tighten the shoulder up. With an open stabilisation, there are two principles. We repair the labrum back to the bone using sutures through the bone. Some people use anchors. I prefer to use sutures, and I'll explain why in a moment. And we tighten the capsule. We make a T-shaped incision in the capsule and we double breast it to tighten the shoulder. In a Latarjet procedure, we remove the coracoid bone from the coracoid stump and we reattach it to the anterior aspect of the glenoid with two large screws to recreate the bony loss. When we looked at my cases over a 25-year period, you can see initially in the 90s we almost always did open stabilisations. In the late 90s, arthroscopic stabilisations came into vogue as a result of significant improvement in instruments and in the type of anchors. And in the early 2000s to 2010, we were doing far more arthroscopic than open stabilisations. And then in the last 10 years or so, we've realised that an arthroscopic stabilisation doesn't work in all cases, and we started doing a few more open stabilisations, including Latarjet procedures. So the take-home message here is that we've learned, especially in the last 10 years, that certain types of pathology need different types of treatments. So what are the advantages of open surgery? Well, we've done a lot of work at Prince of Wales Hospital on this, and with open surgery, instead of using anchors in many cases, we sew the labrum back to the bone, and with that technique we can increase the surface area contact of the labrum and the pressure and enhance healing. We can do a tighter capsular plication, and we can also address any bony deficiency as well as the Hagel lesion if necessary. There have been studies to show that doing a primary stabilisation is much more cost effective in the long term than non-operative treatment, especially in a young cohort of patients. So in summary, a primary stabilisation surgery is more effective than non-operative treatment in patients under 30 years, male patients in particular, high demand sportsmen, and those with labral, capsular and bony pathology. Early surgery reduces the risk of recurrence, it reduces further joint damage, it leaves a more satisfied patient in the long term, and it's a more cost-effective treatment than non-operative management. The first case is a 20-year-old male who suffers his first dislocation in the surf. He presents with a full range of shoulder motion, no axillary nerve palsy, and a positive anterior apprehension sign. And you can see on the MR arthrogram that he has a tear of the anteroinferior labrum. He has no significant Hill-Sachs lesion, and take it from me, he doesn't have a capsular tear. So we see this man, and I talk to him and I tell him that he's young, he's a male, he's active, and the risk of his shoulder dislocation recurring is greater than 90%, and with each subsequent dislocation he's going to do more damage to the shoulder and increase his risk of significant long-term arthritis. In this patient, I would recommend he undergo an arthroscopic shoulder stabilisation, and all one would do would be repair the labrum anteroinferiorly. If we got in there and we found his capsule was voluminous and a little bit lax, we might do a postero-inferior capsular plication. The operation can be done as a day only, but usually as an overnight stay. They're in a sling for 4 weeks, and once they come out of their sling, I start them on a gentle range of motion program with some TheraBand exercises, but I don't allow them to stretch the shoulder for 4 months, so they are a little bit tight, and some of them lose a little bit of external and internal rotation. I don't allow any lifting more than 2 kilograms for 6 months, and I don't let them return to any sport for 6 months. At the end of 6 months, I assess them. If they've had a return of their strength, I allow them to return to full activity. I advise them that the risk of their shoulder redislocating is 5% if they don't return to contact type activities, but the recurrence rate after surgery in contact athletes after 1 dislocation and an arthroscopic stabilisation is about 10%. Some people would say 15%. Case number 2 is of a 25-year-old lady who had her first time dislocation in a fall while rock climbing. She presents with full movement, hypermobility, positive apprehension both anteriorly and posteriorly, and a positive sulcus sign. And if you look at the MR arthrogram, you can see what we term is a Hagel lesion. The normal capsule in a shoulder comes from the bottom of the glenoid and inserts up here into the neck of the humerus. And you can see that the capsule is sitting down here and has stripped off the whole anteromedial part of the humerus. You can actually see the neurovascular bundle of the vessels and the axillary nerve, and it's very close to where you want to take the tissue and reinsert it up here. In this patient, I would do an open stabilisation because I can see the axillary nerve and push it out of the way with a finger if I needed to. I think the risk of this patient getting recurrence of dislocations if they continue rock climbing is close on 100%. And at the same time, by doing an open stabilisation and what we call is a capsular shift to tighten the capsule, we can compensate for her hypermobility by tightening the whole capsule. The third case is that of a 25-year-old rugby league player who sustains a first-time dislocation in a tackle. He presents with limited movement and a strongly positive apprehension sign. The imaging shows that he has bipolar bone defects, a big Hill-Sachs lesion here, some loss of the bone of the anteroinferior glenoid, and an anterior labral tear. When you do a three-dimensional CT scan, one is able to tell this is an off-track lesion. The risk of his shoulder re-dislocating if he goes back to playing football, in my opinion, is pretty much 100%. And in this case, because he has an off-track lesion with bipolar bone damage, I would recommend a Latarjet procedure or a procedure with a coracoid bone graft. Most surgeons do it with open surgery. There are increasing surgeons performing this procedure arthroscopically. At the moment, the arthroscopic Latarjet procedure has a higher risk of complications than an open procedure, but as people's technical skills improve with better instrumentation, I suspect in the future most people will be having their Latarjet procedure done arthroscopically. The rehabilitation from a Latarjet procedure, whether done open or arthroscopically, is 6 to 9 months. There's often a little bit of added stiffness compared to the simple labral repairs. There is a slight increase in osteoarthritis long term if you have a Latarjet procedure as compared to other stabilisation procedures. Thank you for listening. I hope this talk's been helpful. I wish you a great day and stay safe and stay healthy. Thank you very much.
Once again, it's great to have Jerome with us. It's great to see him dressing up. At least he had a shirt on compared to a few other years ago. And what I loved about the talk was the history and the breadth of knowledge. As a man almost in his 70s, I think we'd agree. Jerome gave us this beautiful overview of how thinking has changed with instability. How did you find his talk, Paul?
Well, I have to admit, it turned into a bit of a history lesson for me, and I certainly wouldn't have mentioned his age if I was you, John, but I suppose with seniority you get those kind of privileges. I found it interesting. I wasn't aware that traditional teaching was to wait for 3 dislocations before stabilising a shoulder. I mean, it seems so obvious to us now that every time you have an instability episode, you do more damage. And every time you do damage, you increase the future risk of osteoarthritis. So I thought what Jerome presented was entirely logical, and that certainly in the high-risk patients, we don't wait for them to do it again and again. So I found that history quite interesting.
Look, I think this is where imaging has helped us as well. So this is a situation where technology and imaging has helped us. What about your thoughts, and we'll go to Daron in a moment, I think, on the surgical approaches and expertise that are needed? Latarjet operations have become very popular. We're seeing seeing them done more often. I've got my thoughts. What do you think, Paul?
Well, I've seen several patients who've had Latarjets who actually seem to present with accelerated arthritis. And that's quite an interesting concept, because the whole premise of doing the stabilisation is to reduce redislocation episodes and reduce the risk of arthritis. And I think it's well known that one of the trade-offs of doing the Latarjet is that while you do enhance the stability of the shoulder, and in very high risk patients, and certainly it seems to be an appropriate option, but it probably shouldn't be defaulted to as a first-line operation for people who don't necessarily need it because of this risk of, adverse outcome years down the track. And so I certainly find that...
I actually have to take a little bit of issue with what you said there, because for most people, the Latarjet will stop them dislocating, but it won't necessarily address the instability. You're just giving them a longer bone bridge before they fall out of joint. But I've seen a number of patients that haven't had the soft tissue component of their instability addressed. They've just had the Latarjet, and they still feel that the shoulder is somewhat unstable. And I wonder whether that's one of the reasons that these people are actually getting the accelerated arthritis, because they're now not actually dislocating, but they're not necessarily actually stable either.
So that's actually an interesting concept. I mean, I guess this comes back down to the concept of function as well, and functional stability. But if I can ask you a question, technically, is a Latarjet operation easier than some of the other stabilisation operations? Because I'm just trying to understand why I'm actually seeing it being done more and more as a first line, when from the outside it doesn't necessarily seem indicated.
So in many respects, it is actually easier than, for example, doing an open capsular shift. That's an operation that is quite historical, but works absolutely fantastically in contact athletes who don't have any bone loss. And it's certainly my operation of choice when there's no bone loss. There have been multiple studies coming out recently showing that if you do any form of bone transfer procedure and there isn't bone loss on the glenoid, that bone will reabsorb. And then you've got a couple of screws hanging out in the middle of nowhere, which then become a problem. You have to do a second operation. Now, while technically the Latarjet is somewhat more straightforward, it's also got a much higher complication rate, as much as 12%, even in people who are very experienced at doing the operation. Anything from non-union of the bone graft to second surgery to remove the hardware, or even nerve injury, which can be a permanent nerve injury in younger patients. So you need to be very sure that you're doing the right operation for them. One of the really attractive things about the Latarjet is that you can get them back to sport much faster. By 4 months, most of these people are back playing full contact sport when you've had bone healing of the coracoid to the glenoid. And the other thing is that they don't dislocate again. So, they don't come back to your office with a dislocation, even if they're not actually stable.
So do you think that rush to get people back to sport is one of the drivers for the higher rates of Latarjet operations that we're now seeing out there, and perhaps with patients not necessarily being well informed of the longer term consequences?
Look, I do think that there is an element of that. If you give the patient a 4-month or a 6-month rehab, and most of them will choose the shorter rehab, and we know that the overall redislocation rate after a Latarjet is very low if it's done well, because the shoulder really won't dislocate over a huge bone block, but that doesn't necessarily fix the instability. And that's where making the diagnosis and tailoring the operation to the actual patient is so important. And that's what I really liked about Jerome's talk, is that's what he was talking about doing, was identifying where the pathology was and then choosing the correct operation to deal with it.
He did that very well.
Anyway, Jerome, thank you very much. That was lovely. Our next speaker is Dr. Paul Mason, a very good friend of mine and a fantastic sports medicine physician. And I know you're all expecting another very high-level talk from Paul as he gives us details about diagnosis and treatment of lower back pain.
G'day, I'm Dr. Paul Mason, and today I'm going to bust some long-standing myths about low back pain. It's commonly believed that we have no idea what causes most cases of low back pain. Take this 2017 review article, for instance, which explicitly states that non-specific low back pain has no known pathoanatomical cause, or in other words, it's not possible to know the cause of 80 to 90% of cases of back pain. Well, this is false. We have excellent evidence dating back to the 1950s that most cases of low back pain arise from disc pathology, either directly or indirectly. Let's start with consideration of pain arising from the disc itself. The outer 1 or 2 millimeters of the disc, called the annulus fibrosus, has nerve endings from the sinovertebral nerve, which, when irritated, can cause pain. And this ability of discs to cause pain when irritated has been known for at least 70 years. This paper by a Swedish surgeon was published in 1949. It documents a case series of 200 patients he operated on while awake, a study that would struggle to clear an ethics committee today, explaining why this old research is so valuable. It's simply likely to never be repeated. He used local anaesthetic to provide pain cover to the tissues overlying the discs, meaning he was able to expose the discs themselves without anaesthetising them or numbing them. After exposing the intervertebral discs, he probed the outer disc, in his own words, somewhat firmly, to assess the resultant pain response, all while the patients were awake. And in almost all of the 200 cases, he was able to generate low back pain in what was described as a lumbosacral distribution. In other words, irritating the outside of the disc caused non-specific low back pain. And this paper is one of my favourites. It documents a series of case studies in which nylon thread was passed through and around various anatomical structures in the spine, with the free loops left protruding from the skin, then covered by a sterile dressing. In one of the patients, this nylon was looped through the annulus fibrosus of the L4-5 disc, the outer part of the disc. Then, the day after the operation, the investigators tugged on the nylon loop, and after about 30 seconds of continuous traction, the subject described an ordinary backache. In other words, something akin to non-specific low back pain. We then have this paper from 1991. A series of 193 patients were again operated on while awake, using local anaesthetic for analgesia. First, the investigators exposed the tissues of interest, and then, before numbing them with local anaesthetic, they used blunt compression and electrical stimulation to assess the pain response. The major finding was that the outer disc, the annulus fibrosus, was implicated in low back pain. In 2/3 of the nearly 200 subjects, stimulation of the annulus fibrosus always reproduced their pre-operative pain. Not just caused pain, but qualitatively reproduced their pain. The subjects identified the pain produced on irritation of the annulus as being identical to their usual low back pain. Clear evidence that much so-called non-specific low back pain is actually discogenic. While the annulus can cause low back pain, however, in the real world we don't have someone poking the outside of our discs. Rather, it's internal disc pressures which are most important. Anything which increases internal disc pressures can lead to stress on the annulus fibrosus and has the theoretical capacity to cause pain. And this was demonstrated in this 1949 paper by Carl Hirsch. He reports on 16 subjects who all had severe recurrent low back pain. Using X-ray guidance, he inserted a small needle about 1/2 centimetre into one or both of either the L4-5 or the L5-S1 discs and injected about 2 mL of saline. This increased the intradiscal pressure and in every subject led to reproduction of their low back pain. Identical. He then injected local anaesthetic, which eliminated the pain, proving the involvement of nerves in this process, nerves we now know which are located in the outer part of the annulus. Although it must be noted that in degenerate discs, significant neural ingrowth of the sinovertebral nerve can occur, including all the way into the nucleus pulposus. One thing which is common to all these experiments is that the pain experienced on stimulation of an annulus was always poorly localized and in many cases described as muscular. This is due to the afferent signals from the sinovertebral nerves being carried to the brain via the sympathetic trunk, which you can see here. This makes it a visceral pain, which is like the pain you get from angina or appendicitis, and while aching in quality and poorly localized, it can be severe. Here you can see the pathway carrying the afferent signals from various spinal structures, including discs, the vertebral bodies themselves, epidural vessels, the posterior longitudinal ligament, and the anterior dura mater. These signals are carried along the sinovertebral nerves to the sympathetic trunk, where they ascend before travelling through the L2-3 intervertebral foramen to be carried by the L2 nerve, eventually reaching the brain. The result is that the sympathetic afferents feeding directly into the L2 nerve carry the signal from the lower lumbar spine. Think about that. Pain from most of the lumbar spine is carried along a single nerve, a sympathetic afferent running through the L2-3 foramen, and this information can be used clinically both for diagnosis and for treatment. You see, if we can block the afferent signals arising from the discs and vertebral bodies and other associated anatomical structures, then we can block the experience of pain. So for instance, if we were to perform a block of this ganglion here, then we may be able to stop the pain signals ascending and reaching the pain, therefore blocking the pain experience. And this has actually been demonstrated. In this study, 33 patients with low back pain had a unilateral L2 nerve block on the side of maximal pain. And during the injection, 29 of the 33 subjects felt reproduction of their pain. And afterwards, all patients reported improvements in their back, buttock, or groin pain, and almost complete disappearance in 26 of them. And this is clear evidence that nociception from structures carried by the sinovertebral nerve is responsible for what would otherwise be termed non-specific low back pain. It's also interesting to note that sciatica symptoms were only partially relieved in 3 of the 9 subjects, consistent with radicular pain arising from direct compression of lower nerve roots and being carried along different neural pathways. That is, radicular pain is not visceral pain and is not carried on the sympathetic trunk. And the benefits of these injections were not just limited to diagnosis. The average reduction in pain lasted more than 20 days, despite only using a short-term local anaesthetic. And the prolonged reduction in pain is hypothesized to arise from a reset effect to the sympathetic nerves, which ought to have us reconsider their role in our theories of central sensitization. And this subsequent randomized double-blinded study found L2 nerve blocks led to significant reductions in pain even at 30 days. A bit more drastic, but perhaps worthy of consideration in some cases, is the possibility of lesioning the sympathetic trunks therapeutically. This was performed in this 1996 paper at the L2 and L3 levels. Subjects who had failed to improve following a lumbar laminectomy operation underwent diagnostic local anaesthetic injections at L2, L3 and L4, after which a total of 15 lumbar sympathectomies were performed. 11 of these sympathectomies were deemed to have led to a satisfactory outcome after more than 6 months, all of them occurring in subjects who'd obtained an excellent, albeit short-term response to the local anaesthetic. The 4 unsatisfactory results had all had less than an excellent response to these same injections. This tells us 2 things. Targeted sympathectomy can be an excellent option for those with severe chronic low back pain, and that response to local anaesthetic injections can be used to identify patients likely to benefit from this procedure. Take this case study of a 69-year-old female who'd had a fusion from L3 to S1 for chronic lower back and bilateral leg pain. Unfortunately, while this operation helped her severe left leg pain, after the operation she developed 9 out of 10 severity right leg pain, which failed to respond to multiple injections, none at the L2 level it must be said, and a further 2 decompressive surgeries. After referral to a specialist pain centre, diagnostic sympathetic injections were performed, followed by radiofrequency lesioning of the L2 and L3 sympathetic chains. This led to a resolution of her pain and allowed her to cease 3 pain medications. Let's now consider nerve root irritation arising from disc prolapse. Here is a close-up of a nerve, and in colour you can see the small nerves and vessels which insert into the periphery of the larger nerve. These small nerves are called nervi nervorum and supply sensation to the larger nerve itself. Unlike the signals carried along the nerve itself, the signals from the nervi nervorum are very likely to be transmitted along sympathetic nerves and are therefore visceral. This means that they're poorly localized, resulting in an aching kind of pain. So irritation of a nerve, even without compromising its function in terms of its ability to carry ascending and descending signals, can cause pain. And like other visceral pain, this pain can be referred in a somewhat predictable, if not always exact, pattern. Consider, for instance, the pain around the umbilicus, which usually heralds appendicitis, or the left arm pain, which can signal a heart attack. And the irritation of the nervi nervorum around the larger nerves can be either mechanical, from direct pressure of a prolapsed disc for instance, or chemical, derived from inflammation. The chemical component usually arises secondary to a breach in the annulus fibrosus. This allows the nucleus pulposus, which is normally contained within the annulus, to be exposed to the immune system. You see, the nucleus is normally immune privileged. Being avascular, the disc is normally isolated from the immune system, and when it's exposed to the circulation and the immune system, it's subject to attack, resulting in localized inflammation, which is a direct irritant to the adjacent nervi nervorum fibers. And I believe lumbosacral nerve root irritation, either mechanical or chemical, is the most common cause of musculoskeletal misdiagnosis. This is because it can masquerade by way of referred pain as a number of conditions, including SIJ pain, piriformis syndrome, hamstring pain, ischial bursitis, gluteus medius syndrome, and greater trochanteric pain. Indeed, classical teaching is that if pain is not experienced below the knee, then it cannot be deriving from a nerve, while this belief is demonstrably false. This 1958 paper by Smythe demonstrates rather elegantly the non-radicular patterns of lumbosacral nerve root irritation. In 26 patients, nylon thread was passed around one or more nerve roots during surgery, with the free ends of the nylon left protruding from the skin and covered by a sterile dressing. Then, a day or more after surgery, once the preoperative pain had settled, the investigators began tagging on these threads. And this is the pattern of pain recorded in one patient for irritation of the left L5 nerve root, a similar pattern which I've seen mistaken for piriformis syndrome. In the same patient, irritation of the S1 nerve root led to pain in the region of the hamstring. I would suggest, rather than the term hamstring-related back pain, which I hear not infrequently, perhaps we should be discussing back-related hamstring pain, in recognition of its true origin. In another patient, S1 irritation was able to produce a localized pain in the region of the ischial tuberosity, and I've seen several cases with proximal hamstring or pathology of the ischial bursa that has been wrongly diagnosed. The key point to remember is that pain that is poorly localized with an aching quality is highly likely to be referred. So if you ask a patient to point to their pain and they indicate the area with a wave of the hand, consider visceral referred pain from spinal nerve origin. And the problem of nerve root pain masquerading as other conditions also exists in the cervical spine, and this diagnostic confusion is not helped by the fact that half of all patients presenting with shoulder pain also have concomitant shoulder pain. Conditions which cervical nerve root irritation may be mistaken for include shoulder problems, such as impingement, rotator cuff issues, levator scapular syndrome, T4 syndrome, quadrilateral space syndrome, rib ring dysfunction, and several others. And I suspect the reason for some of these diagnoses, which it must be said there's little objective evidence for, have risen to prominence because of difficulties in actually making accurate clinical diagnoses. This Japanese paper was able to elegantly demonstrate that compression of cervical nerve roots led to neck and scapular pain. The subjects were 50 consecutive patients with cervical radiculopathy who underwent single-level cervical nerve root decompression. The researchers began by mapping out the pain experienced by each subject in the region shown. Before the surgery, the presence of neck and shoulder pain was evaluated for in each of the regions shown, and 70% of the study subjects were found to have pain in these areas before surgery. Here you can see the number of patients reporting pain in each region, and this is 1 month after the surgery. You can see that more reported localized neck pain after surgery, consistent with the incision, but there was a dramatic reduction in the incidence of pain around the top of the shoulder and around the scapula. In fact, the number of patients reporting pain in these regions reduced by more than 70%, and the average duration of pain before the surgery was 7 months. The authors were able to determine predictable referral areas from each level of nerve root. So if you encounter a patient with an aching or poorly localized pain in one of these regions, even in the absence of classical radicular symptoms, consider cervical nerve root irritation as a cause. What then when a nerve is compressed significantly? Well, then the ascending and descending signals travelling along the nerve can be blocked, and this can lead to disturbances in sensory and motor function, as well as causing the classical shooting or electric pain associated with radiculopathy. Classical teaching is that we can reliably use the findings of altered sensation, the region of pain or sensory disturbance, to determine which nerve is likely to be involved. And we've got very well accepted dermatome charts demonstrating which patch of skin is provided for by a particular nerve. Unfortunately, despite their widespread acceptance, these sensory examinations are not able to reliably determine the level of nerve involvement. Have a look at the areas of sensory loss shown in these pictures. The area on the left is usually associated with the L5 dermatome, and that on the right with the S1 dermatome. Well, they were, in fact, both from the S1 dermatome in different patients. A comprehensive study demonstrating the variability of dermatomes was reported in this 1993 paper. 86 targeted single-level nerve root injections were performed, and the resultant area of sensory loss was mapped. And what they found was a surprising degree of variability in the sensory area supplied by each nerve root. It was quite common for the area of sensory supply to basically be out by one level, either up or down, when compared to what was predicted by accepted dermatome charts. Take the big toe, which is widely accepted as being the domain of the L5 nerve root. Well, this study found that the sensory disturbance of the big toe could also be caused by an L4 block in more than 25% of cases. In fact, the accepted level of nerve supply, even in precise areas, was found to be wrong in about 20% of cases. This doesn't make the examination worthless, for it will usually be correct to within a level or so. It's just something that shouldn't be absolutely relied upon. We've also another examination technique to level a nerve lesion, and that's motor assessment. And like dermatomes, motor assessment shouldn't be assumed to be 100% accurate, and this is even worse for higher lumbar levels. In fact, there's such marked overlap of the L2, L3 and L4 innervation of the anterior thigh muscles that it's difficult to differentiate it even with electrodiagnostic testing, and for this reason these radiculopathies are generally now considered as a group. So given the diagnostic difficulties and the varied pain presentations that can result, spinal nerve irritation can present something of a clinical dilemma. I find the most useful means of obtaining an accurate diagnosis with respect to the spinal level of involvement is with targeted CT-guided injections. This involves the precise placement of a needle under CT guidance. This commonly includes spinal nerves within an intervertebral foramina, between the lamina, into the epidural space, or even into the facet joint. Usually a combination of local anaesthetic and corticosteroid is injected, and it's the action of the local anaesthetic which is most useful. If the right spot is hit, severe pain can quite literally be reduced to 0 or less than 1 out of 10 in less than a minute. While this benefit is transient, it's invaluable in securing an accurate anatomical diagnosis. And there's good evidence that these injections can provide short-term relief of symptoms for some months. And there's some evidence of benefit for greater than 6 months. Certainly, they have a role in potentially preventing avoidable surgeries, and even in the situation where CT-guided injections fail to provide a sustained benefit, an immediate diagnostic response is very useful to identify suitable surgical candidates. I'd like now to cover something related to myotomes, and that is muscle atrophy. We can expect to observe atrophy of muscles whose innervation derives from an affected nerve, and this also includes the paraspinal muscles of multifidus and erector spinae. And indeed, it's been shown that patients with nerve compression evident on imaging have atrophy of these muscles when compared to patients who have back pain without nerve compression. The problem is we often confuse the chicken and the egg. While it's obvious that atrophy of multifidus is a result of nerve compression, in my training I was taught that multifidus atrophy was in fact a cause of back pain and that we should instead focus our treatment on targeted strengthening. I sometimes see a similar error of logic in regards to the gluteal muscles. Being innervated from L4, L5 and S1, the gluteal muscles are susceptible to weakness and atrophy with lumbosacral radiculopathies as well. Some patients I see, however, have been advised that their back problems arise from gluteal dysfunction, rather than the gluteal dysfunction being a consequence of the nerve compression. Indeed, on screen you can see the atrophied gluteal muscles as a consequence of a radiculopathy. So giving gluteal exercises to a patient with lumbosacral radiculopathy makes little more sense than prescribing a patient with an S1 radiculopathy calf raises to help with calf weakness. The problem isn't within the muscles, but rather the pathway which conducts the signals from the brain to the muscles. Another muscle-related concept which correlates well with lumbar radiculopathy are trigger points. These are focal areas of tenderness in muscles, palpable as nodules, and a frequent target of therapists, including through dry needling and deep massage. Research published in 2016 found that trigger points in the superolateral quadrant of the gluteal region are highly specific for radiculopathy, based on examination and MRI and electrodiagnostic examination of 325 patients. In fact, the presence of gluteal trigger points indicated a greater than 90% chance of having a radiculopathy. So if you have a patient with trigger points in the upper outer quadrant of the glutes, chances are they also have a radiculopathy. Moving on, in addition to local pain, disc degeneration can contribute to pain via its effect on other structures. For instance, degenerate discs can often lose height. One consequence can be narrowing of the intervertebral foramen where the nerve exits through, potentially causing exiting nerve irritation. Loss of disc height also disturbs the normal biomechanical function of the disc, including its ability to support the weight of the spine above. Healthy discs support about 80% of the axial load of the spine, with the remaining 20% being transmitted through the posterior elements like the facet joints. With loss of disc space height, however, the loading through the facet joints can increase substantially, which can lead to early degeneration of the facet joints. And this is well known, with numerous studies having shown that facet joint degeneration usually occurs secondary to degeneration of intervertebral discs. In fact, facet joint arthritis without pre-existing disc disease is rare. Facet joint pathology in and of itself can cause referred pain overlapping with that from other spinal structures as well. Additionally, osteophytic facet joints can directly irritate both the posterior annulus fibrosus and nerve roots, explaining in part the diagnostic difficulty of isolating facet pathology as a source of pain. One investigation I find useful to investigate facet joint pathology is a CT SPECT scan, which combines a bone scan with a CT scan to provide a localized assessment of facet joint activity, which correlates well with pain. Injections can also be used to diagnose facet joints as a source of pain. This can include injection either directly into the facet joint itself, or injection targeting what are known as the medial branch nerves above and below each facet joint, and which carry the signals from each joint. These injections can prove to be therapeutic, with one study finding that injecting facet joints with corticosteroid and local anaesthetic led to an average of 19 weeks of pain relief. And it's certainly possible to combine different injections together, such as nerve root injections with facet joint injections, not necessarily at the same time. Even longer-term results in terms of pain relief may be obtained through a procedure called radiofrequency ablation, where a probe is inserted adjacent to the medial branch nerves and heated to about 80 degrees. This basically cooks the nerve and destroys its ability to conduct pain signals. And this procedure appears to be moderately successful, with this 24-month data published earlier this year finding that 44% of patients still had a greater than 50% reduction in pain. I'd like to now move on and review the role of conservative management in low back pain. As we've already seen, disc pathology underlies most cases of low back pain, either directly or indirectly. That is, pain may arise from injury to the disc itself or as a result of mechanical or chemical irritation to adjacent structures, including nerves and the dura. There may even be accelerated degeneration of facet joints secondary to disc disease. Whatever the cause, once an accurate diagnosis has been made, our attention turns to treatment. It's obvious that if we have a bulging or protruded disc, that anything that increases the pressure within the disc is likely to lead to an exacerbation of symptoms. If the outer annulus of the disc is breached, however, as occurs with either an extrusion or sequestration, many patients are curious as to what happens to the herniated nucleus. Well, the nucleus is immune privileged, meaning it's not normally exposed to the immune system when it's normally ensconced within the annulus. When it breaches the annulus, however, it's detected as foreign by the immune system, and specialized cells, called phagocytes, proceed to gradually digest it. This process is called phagocytosis, and is in fact measurable with a blood test. Interleukin-17 is a chemical called a cytokine which is found in the blood and is in part responsible for driving this process. Here you can see that patients with ruptured discs actively undergoing phagocytosis on the right have far higher levels of interleukin-17 than healthy controls. And this process usually, if not always, results in resorption of the extruded or sequestered nucleus pulposus fragment. In fact, this meta-analysis found that about 66% of disc prolapses spontaneously resorb, though it can take many months. Here you can see the regression of a large prolapse over a period of 17 months. So this is great news for patients. Even if they have a large extrusion, more often than not, it will resorb due to the action of the immune system. Unfortunately, phagocytosis is also an inflammatory process and can be quite painful, potentially leading to central sensitization over a long period of time. And so for some patients, especially those with debilitating pain or significant motor weakness, surgery may be an appropriate consideration. The fact is, however, the majority of patients with discogenic back pain can be effectively managed conservatively, and probably one of the most important factors in this is intradiscal pressure, or the pressure inside a disc which can exacerbate a prolapse. We gain valuable insight into intradiscal pressure from this 1999 paper. This belt was worn by a volunteer, which had a small rod with a pressure transducer at the end of it. This pressure transducer was then inserted into the center of the L4-5 disc and held in place by the belt. And then, over a 24-hour period, the volunteer engaged in a variety of different activities, during which the pressures in his L4-5 disc was continuously recorded. And these were the results. You can clearly see that lying down leads to the lowest disc pressures, while sitting, if reclined right back, also has lower disc pressures than standing. Note that sitting upright, as is usually recommended, leads to significantly higher disc pressures. Lifting and squatting, even with a straight back, led to a large rise in disc pressure. So clearly we can see that posture matters. The pressure inside the disc is borne by the fibers of the annulus fibrosus, and certain postures are clearly more stressful to the disc. In addition to posture, another factor which influences disc pressure is time of day. The spinal discs are actually composed of more than 70% water, and about 25% of this can both exit and enter the disc throughout the day, and this leads to a predictable change in disc pressure over the course of a day. Basically, discs contain proteoglycan molecules which attract water, and in the unloaded state, such as when we lie down, these proteoglycan molecules attract fluid. Loading a disc can force water out, and the net movement of water reflects the balance of these forces. And when the fluid content of a disc is greater, the stress on the annulus will also be greater for any given activity or posture. And the same paper that measured disc pressures with movement also measured pressures in the L4-5 disc over 7 hours of sleeping. And the pressure, simply lying down for 7 hours, increased 2.4 times. This is why you're about 2 centimeters taller in the morning than before you go to bed, because the extra pressure in your discs push your vertebra apart. This is a graph from a study which measured the height of subjects over a 24-hour period, and it was clearly demonstrated that height increased while recumbent in bed and decreased on rising from bed. And the increase in disc pressure, which predictably occurs overnight, is amplified by the axial loading when we rise from bed in the morning, and then potentially increased even further if we flex our spine. In fact, it's been shown that disc stresses are 3 times greater for the same degree of flexion when performed in the morning compared with performing it in the evening. 3 times greater. Which is why, if you need to get dressed in the morning, it might actually just make sense to pop a dressing gown on and wait for a couple of hours. But if you really need to get dressed, put your socks and underwear on lying down. That way, even if you can't avoid spinal flexion, at least you don't have the axial loading of your spine from gravity further increasing the pressure in your discs. Unfortunately, not everyone can avoid flexing their spines in the morning, such as athletes who typically train early in the day, and this has consequences. This is likely why the lifetime prevalence of low back pain in rowers is up to 94%, and a 2010 study on professional cyclists found that 58% had low back pain in the previous year, with 41% seeking medical attention. Compare this to runners who don't typically flex as much. Runners actually have lower rates of low back pain than the general population, and this recent systematic review even suggests that running could cautiously be considered as a protective factor for low back pain. This study, for instance, found that runners have increased disc height and better disc hydration than non-runners. So next time you have a patient with low back pain, don't suggest cycling as a preferable form of exercise over running. And if you do need to recommend cycling, remember, recumbent cycling places much lower stresses on the disc. And you know what? We've got excellent evidence that simply avoiding spinal flexion early in the morning is an effective treatment for low back pain. In fact, the magnitude of benefit proven by research far outweighs that of any other conservative treatment which I've looked at, including strength and stabilization exercises and stretching. This here ought to be one of the most cited papers in the history of low back pain. Unfortunately, many therapists have never heard of it or read it. It was a randomized controlled trial where the intervention group was simply instructed to avoid spinal flexion for the first 2 hours of the day, and those in the control group were prescribed 6 exercises. The training around flexion avoidance included how to log roll out of bed, instructions to avoid all bending, squatting and sitting for the first 2 hours after rising. Subjects were given advice how to carry out their activities of daily living, and after 2 hours, they were simply instructed to maintain a straight back. So what kind of results did they get? Well, the results were quite impressive. Compared to the exercise group, at 6 months, the average pain reduction in the intervention group was almost 5 times greater. And a significant advantage was still present after 12 months. This is with just a 45-minute educational intervention. And even after 3 years, subjects who had continued to restrict bending activities had 51% less pain days. Findings that really blow other conservative interventions out of the water. I'd like now to briefly touch on something which increases the risk of disc pain, and that's something called stress riser effect. During spinal flexion, each articulation of the spine contributes to the movement. If, for some reason, however, one or more level is blocked from moving, then the adjacent levels will have to compensate by moving more, placing them under more load. We can get a stress riser through something known as sacralization of lumbar vertebra. You can see here sacralization of the L5 vertebra, which effectively blocks the normal motion at the L5-S1 level, leading to increased forces at L4-5. And given that 75% of flexion and extension in the lumbar spine normally occurs between L5 and S1, the potential consequences to the L4-5 disc, which normally only contributes 20% to this movement, are obvious. Incidentally, the articulation between the enlarged transverse process of the L5 vertebra seen here and the sacrum can also cause pain, being called Bertolotti syndrome. A similar type of stress riser effect can arise following a surgical fusion, and this is one reason some cynically refer to this operation as the gift that keeps on giving, meaning that once a patient has had a fusion, it's likely that in the future it will need to be extended to adjacent levels as they deteriorate, sometimes multiple times. This makes it critical that if you have a patient who has had a spinal fusion, that you make sure they understand the importance of restricting lumbar flexion, as this is their best chance of slowing down adjacent level degeneration. Also not always considered is the role of hip flexion. Being adjacent to the lumbosacral spine, within the kinematic chain, any restriction of hip flexion has the potential to lead to a compensatory increase in spinal flexion. In younger people, this is usually due to femoroacetabular impingement, or FAI, and this usually leads to osteoarthritis with age. One good educational strategy for this, which is also helpful for hip pain, is to appreciate that the acetabular rim is deeper anteriorly than it is out laterally, and this can afford for a greater degree of hip flexion when the hip is in abduction than when it's in the midline. Hence, it can be quite useful to perform activities like squatting with the hips in a relatively abducted posture, and this can reduce compensatory flexion in the spine. So let's take a look at a case study. This photo was literally taken less than 2 months ago. On the floor is a 43-year-old male who developed severe low back pain after CrossFit, and he's being put on a stretcher by some firemen. Here he is being carried out to the waiting ambulance and clutching the green whistle inside the ambulance. In the emergency department, he was diagnosed with non-specific low back pain, filled to the eyeballs with medications, and discharged home. Then his luck turned, because he saw a therapist who prescribed him a strict flexion avoidance program for the first 2 hours of each day. And this is his 2-hour timer, which he was setting each morning for this purpose. His therapy also included postural awareness training, which included continual wearing of proprioceptive tape, so he could tell when he was flexing his spine. He was taught strategies on how to avoid spinal flexion. This included using a pickup stick, using elasticated shoelaces with a long handle shoehorn, a lunge, squat and golfer's lift technique to minimize the degree of spinal flexion when he's picking things up, getting dressed lying on his back, and he was also advised to avoid sitting down on the toilet in the morning and to brush his teeth in the shower so he didn't have to lean over a sink. This is his driving position for when he was going to work, and once at work he used a standing desk. And in fact, he was able to return to work very quickly. And if work can be flexible, I actually like returning patients to work as quickly as possible. And it took only 3 weeks for him to come off all his painkillers. And he's now back doing safe exercises, including chin-ups and dips, neither of which either flex or axially load the spine, and recumbent cycling, and gradually building his exercise capacity over time. And this is not a unique story. I know for many of you, what I've presented here today certainly represents a paradigm shift. It certainly was for me compared to what I was taught in the 90s. But please, just give it a go. Your patients will thank you. Thank you.
Paul, just wow, I mean, that's fantastic. You always come up with a fantastic talk, which is scientifically based and super, super interesting. And I learn something every time I watch one of your talks. So thank you very much. John, your thoughts, please?
Look, I concur. The effort you go to, Paul, in your presentations, it's magnificent. The one thing that sort of stunned me when I saw it was pain perception and the inability of a patient to differentiate the pain from nerve root stimulation and muscular pain. I thought that was very interesting because we've often been very vague about diagnosing spinal pain, but the precision of being able to do that with injection techniques I thought was very helpful. And also diagnostic injections. If you could talk a bit more to that and reinforce that, that would be helpful.
Yeah, well, I think the irritation of the nervi nervorum and for the nerve root actually being perceived as muscular pain, I think that really speaks to the ability of low back pain to be the great mimic. And I guess that's why it's got such a protean presentation, both through the shoulder girdle and the hip girdle. And that's where, for me, professionally, the CT-guided injections are incredibly valuable because they can actually then allow us to come back in these areas with overlapping referral patterns to tease out which specific structure and which specific level is actually causing the symptomatology. And as you know, if we're going to effectively treat something, then it always starts with a relatively accurate diagnosis. So certainly I find the use of CT-guided injections to be absolutely invaluable. And it can actually really change treatment because the difference between a facet joint pathology and a nerve root irritation or something coming purely from irritation of the annulus fibrosis, they each have distinct management protocols. So it is actually quite important that we don't just lump everything together as a non-specific low back pain, and that we do try and tease out what exactly is causing the problem.
Look, I think the general principles of that apply just as much to the cervical spine with shoulder pain as well. And we've all seen over the years a number of people presenting with supposed shoulder pathology, but that's actually coming from the neck. And I think your principles can be applied there as well, Paul.
Well, as we know, there have been very reliable studies now that show that almost exactly 50% of people presenting with shoulder pain actually have comorbid cervical spine pathology. So, there's a huge overlap between the two. And, as a surgeon, it can be difficult to tease apart.
Yeah. And, one of the things that I really like about being in our group practice is I've got the option of sending these patients to an experienced sports med physician, or I can send it to one of our spine surgeons, either Samia or Andreas, who all have different ways of dealing with the different problems. So thanks very much again, Paul.
Paul.
Thank you.
And this next speaker is Andreas Loeffler, who was the former president of the Australian Orthopaedic Association, who is a spinal as well as joint replacement surgeon. And he's going to be talking to us today about early recovery from joint replacement surgery, which is a very important topic from both a patient recovery and a financial perspective. Thank you, Andreas.
G'day, I'm Andreas Loeffler, an orthopaedic surgeon from the Prince of Wales Hospital, and I'd like to talk to you today about ERAS, or early recovery after surgery. In 2019 in Australia, we did 51,000 hip replacements and 57,000 knee replacements, and we did our little share of that at the Prince of Wales Hospital, but all this comes at considerable expense to the community. Now, if we go back in time, and it's not so long ago, that hospital stay was long. In Charnley's days, Charnley was the father of hip replacements. He expected patients to bed rest for 9 days. In Japan and in Germany, even today, it's not unusual for patients to stay in hospital for 4 weeks as their funding goes per day. In Australia in the 1990s, it was quite common for hip and knee replacements to be in hospital for 10 days, and this often included some amount of rehabilitation. But on the long term, that's not sustainable. Traditionally, patients were admitted the night before surgery, and this was quite convenient. Patients settled in for a prolonged stay, which is really what they expected. The anaesthetist came and saw them the night before, and often blood tests and x-rays were still ordered. We even had surgical dressers those days who shaved the patient, which nowadays is of course a no-no. But the reduction in hospital stay became necessary as more and more joint replacements were being performed. There was pressure on beds and pressure on costs. There's also a risk with prolonged recumbency causing collapse of lungs, pneumonia, deep venous thrombosis, constipation, perhaps even depression and other complications. Hospital-acquired infections increased with the length of stay, and patients got tired of staying in hospital and wanted to go home. Over the years, between 2007 and 2019, there was a gradual reduction in the hospital stay from 7.5 days to 4.5 for hips and slightly longer for knees. Now, ERAS was not started by an orthopaedic surgeon. It was in fact championed by a Danish general surgeon who thought that we could optimize patients for surgery and for their recovery. We could decrease the length of stay, save money, and accelerate the recovery. Really, all in all, much better for our patients. And part of that was to set the patient's expectations. Kehleth's premise was that we should reduce the stress response to surgical trauma. We could also reduce the complications. We could improve patient satisfaction by getting patients involved in their own care and return them to independent life much quicker than with the traditional methods. All in all, this was also to provide both clinical and economic benefits. Patients are asked to participate in the planning of their own care. Protocols are set up, and these increase staff confidence. Early involvement of physiotherapists is crucial, as it restores function, gives confidence, and provides safety along the patient's journey. We end up with a shortened hospital stay, overall savings, and lower morbidity. The 30-day mortality is also reduced. This comes in several sections. So in the preoperative period, education is most important. Patients are asked to stop smoking and to reduce their alcohol consumption. Nutrition can be improved for those who require it, and in particular there is an opportunity to increase the hemoglobin by giving ferritin infusions where required. We optimize other comorbidities as best possible and get physicians involved. And physiotherapy starts early by showing preoperative exercises, teaching the use of walking aids, which will be required after the surgery, and again to discuss the details of the post-operative protocol. For the intraoperative period, we have a well-hydrated patient, as clear carbohydrate fluids can be had until 2 hours before surgery. We encourage spinal and regional anesthetics. Tranexamic acid reduces the intraoperative blood loss. We try to use warmers to keep normothermia and avoid tourniquets and drains. In some cases, we use navigation and robotics, but this has not yet been shown to speed up the hospital stay. In the post-operative period, we avoid opiates, which make patients drowsy and sometimes sick. We encourage early mobilization, sometimes even starting in the recovery room. And we have at least twice daily physiotherapy with an early discharge plan, and we discuss all this with the patient. We also encourage outpatient rehabilitation. In 2017, at the Prince of Wales Hospital, we had a pilot project which we called Accelerated Recovery from Orthopaedic Surgery. The aim was to have early discharge 24 to 48 hours after surgery, and this, of course, was a multidisciplinary project involving patients, nursing staff, medical staff, physiotherapists, occupational therapists, as well as the hospital in the home. Whilst the primary objective was a reduced length of stay, we also, as a secondary objective, tried to reduce the complications and to increase patient satisfaction. In the pre-admission period, patients were identified if they had low comorbidities, if they had good social supports, and a willingness to participate in the program. Patients were provided with an educational package. Both pre- and post-op activities were discussed, and they had an opportunity to meet the multidisciplinary team. During the admission, we limited fasting again by giving carbohydrate drinks up to 2 hours before surgery. We encourage regional anesthetics and avoid post-operative analgesia involving opioids. Early mobilization within 2 to 3 hours of surgery was sometimes possible. Intensive physiotherapy on the post-operative day, sometimes involving 3 or 4 visits by the physiotherapist to get patients out of bed, into chairs, and again, the discharge plan was frequently discussed and modified with the patient. The discharge criteria were patients getting in and out of bed independently. Patients had to be able to sit and get up from a chair. They had to walk short distances, manage stairs. It was also important that patients had social support, either somebody to take them home or somebody to be at home to help them when they came back from hospital. And they also had to have easy access to the Prince of Wales, should that be required. The discharge itself was then facilitated by the hospital and the community staff. Of a total of 890 patients for hip and knee replacements during that period, 154 were recruited for AROP. They were slightly younger than the average, with a mean age of 56 years. 150 of these were discharged within 2 days of their surgery. If one looks at the length of stay, you can see that hips did slightly better than knees. Still, only 4 patients failed the program. If one looks at the complications, one can also see that hips did slightly better than knees, but both did better than patients having the standard care of hospital stays. The overall complication rate was 3.3% for the AROP patients and 9% for the others. I do have to concede here that younger patients will have less complications, but still the overall program has been extended to more and more patients since. It is a patient-centered model of care. The preoperative assessment and education helps many, and that has allowed us to extend the program to older patients. The shortened hospital stay is slowly becoming attractive to patients. It's a patient-focused plan and can be modified as required. And recovery in the patient's home for those who have been successful has been very welcome. It also involves increased community support. ERAS and EROP are better, cheaper and faster. They are, however, not for everyone. Those patients requiring complex surgery may not be candidates. Some elderly patients, again with comorbidities, make this more difficult or impossible. Mental health issues need to be considered. Social and geographical isolation will also make ERAS impossible. So what's next? Well, as the length of stay has decreased and we now have plenty of patients who go home 1 or 2 days after surgery, it is not surprising that day-only joint replacement is a reality. There are still some funding issues as our hospitals get paid less, but day surgery centers who take up day-only surgery get paid a little more. There are some arguments about who pays for the rehabilitation, but there will be more of this as we get better at treating patients out of the hospital. I'd like to say a little word about rehabilitation because there's an argument about inpatient or outpatient rehab. Inpatient rehab is popular, especially as patients have heard from their friends what a good time they had in a particular rehab hospital. But inpatient rehabilitation is expensive. Studies have shown that at 6 weeks post-operatively, the functional results are the same for inpatient and outpatient rehab, but the costs can be 10 times higher for the inpatients. Funds are starting to refuse payment for inpatient rehabilitation, and we should be mindful of costs. The ideal model of care is one which is individualized for each patient. We should plan the journey for each patient. We should also manage the expectations and discuss the details before their admission. Discharge should be into a safe place so that patients can be confident of their outcomes. This often involves family and friends, which in turn actually promotes social cohesion. The potential savings are huge. If we look at 108,000 joint replacements last year, and these increase every year, and we look at the fact that an extra day in hospital costs approximately $1,000, one can calculate that 1 day less per patient may give a national saving of $100 million per year. Whilst we are not bankers but professionals, we can act in the best interest of patients by encouraging a speedy recovery with less complications and less risks. This is a challenge and a team effort for all of us. I thank you for your attention and hope that you found some of these facts interesting and helpful.
So I thought that was a really interesting talk. And I mean, I don't just say that because I used to be a physio, but I really, I firmly believe in the benefits of rehabilitation and accelerated rehabilitation. But I know, Daron, that you've started referring patients back to their physio before their operations.
Look, it's absolutely clear that the stronger and fitter you are before your operation, the faster you recover from the operation. I think that's intuitive. It makes a lot of sense. And the great thing is that the physios are quite skilled at changing the exercise so that they can do many different ways of building muscle without necessarily load bearing. So, it's very hard for a patient with knee arthritis to do squats or lunges or go for walks. If the physio is a little bit creative, they can still strengthen them up really nicely. So John, I know you've had some arthroplasty procedures. What were your thoughts on watching that?
Look, it's a journey. For many of our audience have been through this as well. For me, I've had both my hips replaced, and I've got to say, having a physio who you trust to go beside you on this journey, to know you as a person, how you respond to treatment, going through the ups and downs as well of pain, pre and post-operative, more pre-operative is helpful. So really, I was not surprised at all to look at those outcomes that Andreas presented. And I think the important thing is post-operative to help your patients reset goals on a continual basis and even consider living out a few dreams. What are some things they never got to do pre-operatively that they could do post-operatively? And that's been my life experience. Very fortunate.
And so picking your patient with this is also really important. Knowing that you're not necessarily going to get your 90-year-old frail patient out of bed an hour after their major joint replacement, but the 55-year-old is otherwise healthy, you need to push them really hard. But Paul, did you think it was interesting that there was no difference between the inpatient and outpatient outcomes?
Well, I think it really speaks to the skill of outpatient therapists. So, I mean, I guess that's no disrespect to the inpatient therapists within hospital. It's we have a lot of skills and a lot of talent, and I think that this is one area where physios are really underutilized. If we can get the same results outpatients as we can inpatients, we save on hospital bed time and so on and so forth. The patients prefer it. I really think this is something where we as a medical profession should be doing our bit to try and encourage these referrals, which are very, very appropriate, both preoperatively and postoperatively, to the physios, because it really does lead to better outcomes all round. And I think that, I certainly know within Orthosports, we encourage the role of physios, but it's probably something that the medical community, the wider medical community, needs to take on board as well.
And being a member of a couple of medical advisory committees, you really see the sorts of things that can go wrong when you're in hospital. And I think getting out of hospital quickly, generally speaking, is a very good thing for everyone.
Agreed.
Probably I just need to call my insurer now for the moment.
Many, if not most of you, know Dr. Paul Annette. Paul's an experienced and highly regarded sports and exercise physician working out of our Hurstville rooms with elite involvement in rugby league. And in fact, he's talking to us from the team camp of the New South Wales Blues as part of this year's State of Origin series. Paul's got an interesting talk, important and a little different, looking at factors that mimic sports medicine presentations. So thank you, Paul, very much.
Good evening. Dr. Paul Annette's my name, and I welcome you today from the sunny Magenta Shores Resort in camp with the New South Wales Origin team 2020 for the upcoming State of Origin series. The topic I'd like to present today is on musculoskeletal mimics. This is a topic that I've been considering presenting for a number of years, as I feel a lot of the conditions that will be discussed throughout this talk are important conditions that you may encounter commonly within your physiotherapy practice. The first case that I'd like to present is Mr. AS, a 25-year-old male who presents to your clinic with a 3-month history of left knee pain, swelling and stiffness. Of note, this has come on fairly without any significant trauma and fairly insidiously. So he presents to you as the physiotherapist and has his standard treatment, including treating the knee fusion, doing work around the soft tissue structures of the knee and commencing a rehab program for his quadriceps and gluteal muscles. It may have also been suggested that he take an over-the-counter anti-inflammatory medication. The question I always pose in a patient like this, and any other patient you see in your clinic, is why has this happened? He's a young man, 25, unlikely to have osteoarthritis in the knee. There's been no significant history of traumatic event, yet he's presented with a knee effusion for no obvious reason. The importance of this is that I would consider in all presentations of musculoskeletal symptoms, a medical condition should be considered. Just because a patient plays sport and develops a musculoskeletal symptom does not always mean that it's due to injury. And just because an 11-year-old boy plays soccer and develops knee pain doesn't mean that he's had an injury. He may simply have a more sinister problem going on there, such as a bone tumour. As I'm sure you're all aware nowadays, often the primary presentation of any musculoskeletal complaint is to a physiotherapist, or in my experience, they've usually tried the chiropractor, osteopath, naturopath, massage therapist, and even Reiki practitioner before they actually make it to see a medical practitioner. As Mr. AS is more likely to see a physio for his initial assessment and diagnosis than his GP, we must always consider the potential for an underlying medical condition. What are the main conditions that we should consider, and I would like to consider in this presentation today? The main conditions to consider are inflammatory arthropathy, either in the form of rheumatoid arthritis or a seronegative arthropathy, including ankylosing spondylitis, psoriatic arthropathy, or enteric arthropathy. Other presentations could include crystal arthropathy, such as gout, potentially cancer, either primary or secondary, and also associated neurological conditions. What are some of the common symptoms of inflammatory joint disease that would make me concerned that this could be an underlying problem? One of the main ones is actually an absence of precipitating event or injury. In the past, I've had a number of patients referred to me for an ankle sprain with pain and swelling with no history of trauma. Inflammatory symptoms may include swelling, morning or start-up pain, and pain that improves with activity and worsens with rest. Also, a response to medication, such as anti-inflammatories, may be consistent with an inflammatory condition. A positive family history should always be asked for, and also associated symptoms, such as skin rash or psoriasis. I'd like to present some more cases now to try and illustrate different presentations of medical causes of musculoskeletal symptoms. The first is Mr. GG, a 57-year-old and very pleasant man who presents with a 2-month history of right forefoot swelling, but particularly around his third toe. He attributes this to doing increased training with skipping, wearing poor footwear, but unfortunately his symptoms have not settled with boot immobilisation or intermittent anti-inflammatories. Otherwise, he's medically very well. This is a photo of his foot, and the main abnormality we can see is the noticeable and generalised swelling of his third toe in comparison to his other toes. This condition has a specific name known as dactylitis, or colloquially known as a sausage toe, as it clearly looks like a sausage. If you ever see this in a patient, it is always abnormal and almost invariably related to an underlying inflammatory arthropathy. An X-ray is important to obtain to exclude a fracture, although in this case there was no history of trauma. Mr. GG improved with regular Mobic 15 mg daily, although continued to have ongoing symptoms. A basic inflammatory blood screen was normal, and he subsequently did very well with the cortisone injection given into his third MTP joint and second and third intermetatarsal bursa. He was referred for a rheumatology review, but his symptoms settled and no further medication or treatment was required. So what constitutes an inflammatory blood screen? This should include as a basic set of tests a full blood count, and generally blood salts and liver function tests. It's important that the tests include both of it, an ESR and a CRP, to assess for inflammation in the body, full stop. Whilst these are non-specific tests, when they are raised, it is much more significant in terms of a medical presentation. The patient should also have uric acid tests performed to look for underlying gout, and also iron studies, as iron overload or hemochromatosis can be associated with degenerative joint conditions. It's important to perform a rheumatoid factor and also to look for the potential for genetic causes of his symptoms, and in seronegative arthropathy, that HLA-B27 may be positive. In addition, consideration must be made for performing an ANA and other more specialised inflammatory blood tests. The next case is Mr. MD, a 45-year-old fellow who is well known to me as both a builder and a golf player. He was actually seeing me for a coexistent meniscal tear with a strong history of trauma, although at the same time he mentioned a very non-specific and 3-month history of bilateral shoulder girdle pain with quite a significant period of morning stiffness, at least until mid-morning, and a feeling of generalised fatigue. There was no precipitant to this, and he's been able to continue on with his normal activities, common including building and golf. Of note, his clinical examination of the shoulder was quite normal, including a normal range of movement, rotator cuff strength, and negative impingement tests. Whilst his symptoms were quite non-specific, they did sound very inflammatory, particularly the long and protracted period of morning stiffness. He was investigated with a set of inflammatory blood tests and had quite a markedly raised CRP and a mildly raised ESR. A potential diagnosis of polymyalgia rheumatica was made, and he was treated with prednisone 20 milligrams daily with almost immediate relief of his symptoms. Polymyalgia rheumatica is an inflammatory condition of cause unknown, typically occurring in patients over 50 and more commonly in females and males and Caucasian. It generally presents with proximal limb girdle pain, both in the shoulders and the hips, and most notably a significant period of morning stiffness that improves with activity. It is extremely sensitive to prednisone, and not uncommonly a test dose of prednisone may be used to try and make a diagnosis of PMR. It's important that patients who you're considering to have PMR should be referred for inflammatory blood tests, including an ESR and a CRP. The next case is a 23-year-old female who presented with a 3-year history of non-specific left lower back and buttock pain. She noticed the pain was worse with prolonged sitting and standing, and there was some morning stiffness for around 30 to 60 minutes. She felt her pain did improve with activity. Clinically, there was pain more on extension and quadrant testing, and she had a strongly positive Faber's test, so putting the hip in the position of flexion, abduction and external rotation. In addition, she did have a positive posterior pelvic provocation test. This is her MRI scan, and on these particular T2 weighted signals, we can see quite marked inflammation and secondary bony edema around her left sacroiliac joint. She was initially commenced on Mobic 15 milligrams daily, which she did find helpful, and a set of blood tests demonstrated again a raised CRP at 18.2, and she was positive for a HLA-B27. She was referred for a rheumatology review, and in this case was commenced on second-line agents, initially with solazepirine. Other agents that may be used include methotrexate and also, more recently, some of the newer biological therapies. Spondyloarthropathy is a type of inflammatory joint disease which affects predominantly the axial skeleton, but it can include peripheral joints as well. It is important to consider this, particularly in young men who have insidious onset of lower back pain, but it can also occur, as seen here, in females. Generally, there should be morning stiffness that lasts for more than an hour, and true sacroiliitis presents with buttock more than lower back pain. From a clinical point of view, the Faber's test in true sacroiliitis should be extremely positive. Associations may include psoriasis around the knees and elbows, or potentially inflammatory bowel disease. It's important to mention these in your history when assessing a patient with lower back pain for the first time. The next patient is Mr. M.A., a 40-year-old male. He presented with a 6-month history of mid to upper lumbar pain without any precipitant. He had had half a dozen sessions of chiropractic and unusually had not had an X-ray performed, as this does usually make up a standard part of their assessment. Of note in his history, he did have a past history of melanoma 6 years before. The question with a patient like this is, should we be worried? I'm sure you're all well versed in the findings of red flags, which could include constant pain, night pain, weight loss, fever, and being generally unwell. Any patient who has had a past history of cancer should be considered to have a secondary cancer unless proven otherwise. The two main conditions are melanoma and breast cancer, although colon, lung and kidney will also refer to bone. Consideration should also be made of primary blood cancer, such as leukemia and myeloma. Unfortunately, an MRI scan in this patient did demonstrate secondary melanoma throughout the spine. As might be imagined, this was quite a tough consultation in a 40-year-old fellow with a young family. I'm pleased to say that he has done very well with one of the new biological medications used for treating myeloma known as Keytruda, and he's currently now cancer-free. The last case is a 47-year-old fellow who was referred to me with a 6-month history of right lateral elbow and forearm weakness. He was a builder and extremely manually active, but interestingly enough had never really described pain. He had had 8 to 10 sessions of physiotherapy with some mild improvement, and he was referred by his general practitioner for consideration of either cortisone or PRP injection. This fellow's clinical examination demonstrated a negative third finger extension and grip tests, and only minimal tenderness around his lateral elbow and forearm. What was most startling was that he had a global weakness of his right greater than his left arm muscle groups, which was between both C5 and T1. This included reduced biceps jerk and triceps jerk, although a normal sensation. It seemed clear at the time that there was a more sinister neurological issue going on. The question was which one. And again, this was another tough consultation in a young man with his wife with what appeared to be a serious neurological consideration. My initial thoughts were he may have either had motor neuron disease or possibly MS, and it was later borne out that he had developed early stage motor neuron disease. So what is my take-home message from this presentation today? Firstly, in all musculoskeletal presentations, medical conditions should be considered. An absence of a precipitating factor is an important negative. Just because someone presents with pain, don't always attribute it to being part of an injury. Consider inflammatory conditions and also nasty things, including cancer, based on history and examination. And always suggest medical review to your patient if the story is not adding up. Even though sometimes it feels like we're at the end of the line for review, a well-trained GP or sports medicine physician will always be able to add to the diagnosis of medical conditions in your musculoskeletal patient. Thanks.
Guys, I really found that very helpful. I thought one of the things Paul did very well there was looking at peripheral pathology and how it may be a manifestation of generalised or systemic pathology. And Paul, I know that you've got a real passion for inflammatory disorders and looking at connections with body systems. How did you find Paul's talk in that way?
I'll I loved it. I mean, as you know, this is quite close to my heart. I trained as a physio over 20 years ago, so I've missed I'm certain every single diagnosis that Paul presented at some point in time over my career. But I guess now I've developed a bit of a radar for identifying musculoskeletal seeming presentations that actually have a systemic element or systemic cause to them. And I guess probably some of the key ones that is overlooked is the insertional tendinopathy. So say an Achilles tendonitis that's not within the substance of the Achilles, but right where it plasters onto the back of the calcaneus, or even a plantar fasciopathy right at the medial base of the calcaneus there. And they frequently have a strong association with the seronegative spondyloarthropathies. And I guess the other name for an insertional tendinopathy is an enthesitis. So I always have a very high index of suspicion if I'm seeing a patient present with this to go through the rest of their history, talk about, do they have any gastrointestinal symptoms, bloating, frequent constipation, diarrhea, abdominal pain, features that could be consistent with an inflammatory bowel disease, which we know is a strong association. Do they have eye irritation for uveitis? Do they have psoriatic plaque, these red sort of scaly plaques on the skin, usually over the extensor surfaces of the elbows or the knees? And it's surprising how often you find a condition like this that's been managed for a long time with mechanical therapy and different modalities like that, that actually turns out to have a completely different cause. And I think physios are the prime people to actually identify these, because quite frankly, a lot of doctors lack the physical examination skills to actually differentiate between what an abnormal and a normal Achilles tendinopathy is. They don't really know if it's insertional or not. They're sort of a little bit, I guess, less nuanced about their diagnosis. So I think this is a real area that physios can actually take control and, direct the patients in the correct directions.
But yeah, I mean, part of the interesting thing as well was the fact that he really, if the history and the diagnosis don't fit well, you really need to start thinking about, is there a different diagnosis? With no history of trauma, is this going to be a traumatic injury versus a chronic injury as well? And so, we need to, again, be diagnosis focused, try and make the diagnosis before you start your treatment with the patient.
Yeah, so I think there's some diagnoses that are based on tissue disruption. So I mean, like an ankle sprain or a hamstring rupture or something like that. And they tend to require, they tend to be high velocity injuries, not always, but they require a lot of force and an acute traumatic episode. So I think we should always be careful about making a diagnosis of something that usually requires tissue disruption to occur if we don't have an acute traumatic precipitant.
Yeah. All right, that was very interesting. Thank you. Our next speaker is Dr. Todd Gotthelf, who is an orthopaedic surgeon who specializes in foot and ankle and shoulder surgery. He works with me at Concord Public Hospital as well as through the Orthosports rooms. And today he's going to be talking to us about a very important topic of Lisfranc injuries.
Ankle and shoulder surgeon. And today we're going to be talking about Lisfranc injuries. So let's get started. Now, the Lisfranc joints are tarsometatarsal joints, which are the joints of the midfoot. And as you see on the right-hand side, it involves multiple joints of the midfoot. These bones are interlocked with each other intimately to create a stable surface of the midfoot. These joints can be injured, and there needs to be an increased awareness of these injuries because they're a fairly common injury in sports. They can result in a great disability in return to sport. And when people present to the emergency room, up to about 20% of these are overlooked on initial radiographs. Patients will often come into the emergency room with foot pain. X-rays will be done that are non-weight bearing. And these injuries are very subtle injuries, almost often with no fractures. And they can be missed, and people will be sent home with what they are told are sprains. However, they can't return to their sport, and they're off sport for a prolonged period of time. And when these injuries are left untreated, it can lead to arthritis and significant disability. These injuries were first described by Jacques Lisfranc. He was a French gynecologist from the Napoleon era, and he described injuries and midfoot amputations. And so the name became Lisfranc. I'm not sure why being a gynecologist has any relevance, but nevertheless, that's where the name comes from. So the Lisfranc injury is one of the most common athletic foot injuries, and it can occur from various mechanisms. One is a direct injury or a crush to the midfoot. Another is an indirect injury with a twist of the foot with the foot planted. A common mechanism would be with the toes planted. The ankle is in plantar flexion, and there's a forceful abduction of the midfoot, or pressure placed on the heel from a tackle, which puts stress on the midfoot at the same time, resulting in ligamentous injury. So if we look carefully at the anatomy, what we see here is that there is a medial cuneiform which attaches to the second metatarsal, and that's where the Lisfranc ligament attaches from. All these bones are interlocked together intimately with each other, so that stress from one bone to the next can be done seamlessly and allow for stable midfoot when people are running. The bones offer primary stability and are held together by strong ligaments. If we take a look at this image, we'll see in the midfoot, you can see how the bones are constructed and similar to a Roman arch, where each block transmits stress to the next block. And as a force you can see on a Roman arch comes from above, the force is transmitted through each bone out to the sides. And this works the same way as our bones of the midfoot. So when these bones are separated and not intimately together, the whole structure can collapse. To look at the ligamentous anatomy, there are very strong plantar ligaments, and these are where the strength comes from in the midfoot, whereas there are weaker dorsal ligaments. The Lisfranc ligament is the name, as the name applies, is the one that you see number 2, which is from the medial cuneiform to the second metatarsal. You can see in this ligamentous structure that there is no attachment from the first metatarsal to the second metatarsal. The attachment medially to laterally comes from this Lisfranc ligament. There are grades to Lisfranc injuries. Here on the right-hand side on this slide, you can see a severe Lisfranc fracture dislocation. And this occurs from a high-energy injury, such as a motor accident. This is an obvious displaced fracture, and this requires surgical treatment. With these, the principle is to restore the anatomy as much as possible. You can see here plates and screws are used, and with multiple comminution, the anatomy is attempted to be restored as much as possible. What we normally see, however, in the athlete is the subtle Lisfranc injury. And usually with these sports-related activities, it's a lower energy injury. It's often ligamentous, and so there's maybe an avulsion fracture, but often no severe fractures. And so the x-ray can be a subtle change. And what you can see on this x-ray with the arrows pointed is a widening of that 1-2 metatarsal interval, which is suggestive of a Lisfranc rupture. Now, when we're evaluating someone with a Lisfranc injury, it's important to get the history so you can understand the mechanism of injury. This may initially be ignored as a sprain, but patients may be unable to sprint or do any cutting sports. And if you have an athlete who has had an ankle sprain or any sprain and they were evaluated and they were told to go home, that it was no fractures and they can't get back to sport, you should always be mindful that this could be a Lisfranc injury and should be evaluated as such. The first step is to examine them and stress the midfoot and see if there's any pain in the 1-2 interspace. If there is any suspicion, then the next step is to get weight-bearing x-rays. Here you can see an example of a weight-bearing x-ray and a non-weight-bearing x-ray. On the left is a non-weight-bearing x-ray, and when you look at the patient's weight-bearing x-ray, you can see a widened 1-2 interval, and that's because when there's weight bearing, it stresses the ligaments and shows the instability, whereas in a non-weight bearing x-ray, you may not have the instability. So this is the importance of a weight bearing x-ray when assessing for a Lisfranc injury. It's also important, if you look here, to get the opposite side to compare, because everyone has a different pattern and a different wideness to their normal anatomy. And looking at the opposite side to compare will help us to determine if there's any differences. And you can see here there are differences. The one on the right shows a widened Lisfranc interval, then the one on the left, which is normal. MRIs can be done to assess Lisfranc injuries, and in a subtle Lisfranc where you might find that the weight-bearing x-ray possibly looks wide, but you're not quite sure, then an MRI would be a good test to get, because this can show if there was in fact any damage. And so, like this example of an MRI on the right, there is a Lisfranc rupture. You can see the edema around the bones, the disruption of the ligament. In this case, you can see obvious widening, but sometimes the MRI it doesn't show widening, but this does not prove instability because it's a non-weight-bearing study, and therefore an MRI may show you that there's a Lisfranc ligament rupture, but the next step might be to do an evaluation and manipulation under anesthesia to prove if there is any stress instability if a weight-bearing x-ray can't be obtained. A weight-bearing x-ray, though, is usually the first step to see if there is any instability of the Lisfranc ligaments. A CT scan can also be done to assess the Lisfranc ligaments and assess for injury. This is also a non-weight-bearing study, and so it doesn't demonstrate dynamic instability. If there is gross widening, then usually this can be seen on x-rays too, so a CT scan doesn't really offer that much more information. It's not really helpful with subtle sports Lisfranc injuries in that sense because it's not really adding more information. What it can help with is if there's multiple fractures, and if you want to assess for any intra-articular fractures, then a CT scan may be helpful for Lisfrancs in this regard. Now, like I was saying, if a weight-bearing x-ray can't be done, or if it is done and there's a suspicion, or if an MRI is done that shows a Lisfranc injury and you're unsure if there is any instability, the next step would be a manipulation under anesthetic. So with an anesthetic under general, the foot can be manipulated under intraoperative imaging, and this can show if the Lisfranc ligaments are disrupted and if there is frank instability. And if there is, then fixation would be important to stabilize the Lisfranc joints. Here you can see a video showing a Lisfranc injury in theaters, and you can see how the midfoot is flexible and not stable. We're going to now show you the normal side. And I believe these are the hands of John Best, our great sports physician in one of my cases. And you can see here the normal side is not opening up as much as the affected side. Now we've shown you the 1-2 interspace widening, and this was to pretty much simplify Lisfranc injuries. But what you can see in this complicated slide on the right is that there's many different patterns and classifications of Lisfranc injuries. And so it's important to understand these patterns and to look for which might be some different patterns of injuries that might show up. The most common one being the 1-2 interspace widening, but there are others as well. For instance, if you look at this image, the one on the left being normal, and the one on the right, what it shows is a pattern of instability, not just through the 1-2 interspace, because you look at the second metatarsal, it's in line with the middle cuneiform. But what you do see is a widening in between the cuneiforms, and then in between the medial cuneiform and the navicular bone. And so this whole area was disrupted as one. And that's a different pattern of Liz Frank, but equally as disabling and needing to be stabilized. So when you're doing a fixation for Liz Frank injuries, these patterns must be assessed. And when you're seeing the one like I just showed you, you want to stabilize the cuneiforms, also to stabilize the Liz Frank interval when needed, and stabilize any other tarsometatarsal joints that may be unstable. This is done through an open incision so that the anatomy can be restored perfectly. As we said, we want to restore the Roman arch so that transmission of energy can be made from one bone to the next, and the function of the midfoot is restored. My surgical preference is to do an open incision so I can visualize all the joints in two planes. I use solid screws across the Liz Frank interval, and I often use plates with screws to avoid putting screws across the joints. Usually after surgery, patients are non-weight bearing for 6 weeks in a boot, immobilized. After this, they're usually weight bearing in a boot for about 4 weeks. And then after this, they can walk without any boot, but they can't play sports yet. Oftentimes at this stage, I like to get them an orthotic and an arch support to support the midfoot. And at about 6 months, all hardware is removed. And once the hardware is removed, athletes and patients can get back to their normal activities pretty much as soon as they're comfortable. A lot of patients often find this difficult. In the initial sense, there could be some inflammation and swelling, and usually this sort of thing will settle down over time and allow patients to get back to their normal activities. So when do we have people return to sport? Well, there's little proven in the literature. We want to avoid any late diastasis, and we want to get patients to return to their full sport. There's an article which looked at this in 2012, and they usually got patients back to training at about 24 weeks and playing at 31 weeks. So you can see that these injuries are very disabling and take a long time to recover from. Bony injuries can sometimes take longer. I wanted to touch on the delayed Liz Frank because if they are missed and then they present at a later date, what should we do about them? Well, because the ligaments heal at a certain time and there's no longer biological healing, it becomes a problem when patients come with a delayed Liz Frank. Usually, if you catch them within 6 weeks, usually you can do a primary stabilization in a similar way, and you might, as you go in and do an open surgery, just irritate the joints where you're reducing them to create some more scar tissue and reduce the joints and put your plates and screws in. If the injury is seen at greater than 6 weeks, it's more difficult to get some biological healing happening, and so it becomes a problem of what to do at that stage and what will work. Sometimes with subtle displacements, you can get away with initial non-operative treatment using an arch support orthotic, and sometimes patients will settle down over a 12 to 18 month period. But if they don't settle down and they're not getting any better and they can't return to sports, And often a Lisfranc fusion is a good choice to stabilize the joints, and once the joints do fuse, they can get back to sports and activities again. Sometimes in delayed Lisfranc injuries, there are large displacements. And so after 6 weeks, if there's a large displacement, it might not work to primarily fix these, and a situation may occur where a fusion might be a more reasonable thing to do. The second thing that may occur is that early arthritis may develop. Now, this may not be detected on x-rays, so an MRI is often a good choice to see if there's any arthritis forming in the joints. If there is, a primary fixation is also not favorable, and so it's unlikely to do well, and a fusion would be a likely more successful operation to allow someone to get back to their sports and activities. So in this, if you can see on the right in this photo image of a fusion, when we do a Lisfranc fusion, it's the first, the second, and the third TMT joints that are also involved. This represents the medial column of the foot, and it's the stable portion. You don't want to fuse the fourth and fifth TMT joints. These should be flexible. And with a fusion, you can often get people back to their activities, and you can get athletes back to sports. So in summary, one must have a high suspicion for a Lisfranc injury. It can be a subtle injury sometimes, and you need to look for 1-2 interspace pain, inability to perform in cutting sports, and if this is the case, it should be evaluated with weight-bearing x-rays, and getting x-rays of the opposite side to compare. If there's any concern about the x-rays, if there's still concern about a Lisfranc, but the x-rays don't show it well, an MRI is a good choice to look for a Lisfranc injury. And if there's high suspicion, referral to an orthopedic surgeon so that a consideration can be made for manipulation under anesthesia, possibly operative fixation at that time. Once a Lisfranc is fixed, usually there are 6 weeks non-weight bearing and no sports no earlier than 6 months. Thank you very much.
So that was a really interesting talk there. And for such a serious injury that is absolutely disastrous if it's mismanaged, a lot of them are actually missed on plain non-weight bearing x-rays.
Yeah, and you see, that's what happens in the emergency department. If the person has had some sort of injury, whether it was a car crash or something like being on a rubber ducky where they've had their foot bent the wrong way, when they come in, the standard emergency department x-rays are with the patient lying down. And so it really is a problem. John, I'm sure you've seen these over the years with some of your football players.
I've got no doubt I missed them early in my career as well. The diagnosis hasn't, I think, really been well taught and appreciated until probably the last 15 years, I would suggest. But again, the point of the x-ray in a weight-bearing film, when it's functional, that's just gold, that information, as opposed to a misdiagnosis with scarring in the wrong position. So bilateral weight-bearing film, so have a comparison film. I think that's very, very good advice.
But it comes back to, again, the history, the examination, and then making a diagnosis in your mind before actually starting treatment. Which, again, was one of the points you were making in your talk as well, that's what's critical with all of this.
And the interesting thing too is that you can't just rely blindly on an MRI. While that can demonstrate an injury to the ligament, it can't actually demonstrate instability. And the whole question about, surgical management is premised around whether it's stable or not. So you actually need to, as you just said, John, you need to load it. It needs to be a functional test.
Yes.
And a weight-bearing x-ray, I guess this is the one caveat there, that as good as x-rays are, they need to be the right x-rays. And in this situation, it needs to be weight-bearing so that you actually allow separation of the joints if it's present. And you need to be bilateral because you will have variation in the natural spacing between the bones between different individuals.
That's right. That's exactly right.
And it's much better in this particular situation if you suspect it and you're not happy to get the imaging, refer the patient early, because this is one of the times, for example, Paul, you've heard me complain about distal biceps injuries that turn up late as well. This really is a time-critical injury. And if you miss that magic window at the first 6 weeks or so, it's really hard to get them right afterwards.
I think if people haven't actually been witnessing surgery being done, I think it's easy to overlook the fact that scarring and fibrous tissue that forms in that first 6-week period actually can not just make surgery difficult, but in some cases it can make it near impossible. And I've actually seen some delayed presentations of Lisfranc injuries that have actually literally been career-ending, simply because they weren't picked up early enough.
And if you remember Jerome's talk, he was talking about having an arthroscopic stabilization also done in the first 6 weeks with all the healing factors in there. So I think this applies to most parts of the body if you can get there acutely.
Well, I guess the point is, if you think that something may require surgical management, it's best to get an opinion on it sooner rather than later. For some things, it's actually quite reasonable to wait. Say if it was a knee arthritis and you're worried about a total knee replacement. And I think most chronic conditions, it's actually quite reasonable to delay surgical referral. But for acute injuries, if they may need surgery, refer early.
Yeah, I think that's a good point. Thanks, guys.
It's great to have Dr. Lee Golding with us as a new fellow and a new member at Orthosports. Lee joined us at Orthosports Randwick after completing his fellowship and has a background in elite rugby league, rugby union, and recently appointed as team doctor for the Australian cricket team, which is a great achievement. Lee's going to be talking to us about touring with the team during the COVID era. So thank you, Lee, very much.
Hi there, my name's Dr. Lee Golding. I'm a sports and exercise medicine physician at Orthosports, and I work in the Randwick rooms. And I was also recently the doctor for the Australian cricket team on their trip to England during this global pandemic. So this is just going to be a short talk about some of the experiences I had in undertaking this tour. Hopefully you'll find it interesting. It was a unique tour. And it actually took a lot of planning. It was uncertain it was going to go ahead for a long period. And in the lead up, a lot of our planning involved talking to the players, running formal surveys, and actually finding out what worries and concerns they had about the dangers of traveling during these times. We provided online education sessions about what a biosecure hub would look like, but also on safe PPE use and the logistics of getting around travel safely on a trip like this. The pre-tour isolation requirements varied quite significantly depending on what state the players and the tour group were living in. But for example, those of us that were living in New South Wales were required to self-isolate for 14 days prior to travel and to have swabs on day 14, day 7, day 3 before we travelled, just to make sure that there was no risk that any of us were carrying COVID on the plane. We also asked everyone to undertake daily symptom monitoring, and we devised a custom app that allowed everyone to put in their temperatures in the morning and also to mark their symptoms and whether they had any symptoms before they left their rooms each day. We performed household screening of all the households of the players just to make sure that there were no high-risk individuals joining our bubble, amongst a lot of other tasks that we kind of did over a period of about 6 to 8 weeks before the tour began. The travel and the flying was a particularly surreal experience. We had to organise private charters from the high-risk states, so from private planes from Sydney and from Melbourne, in order to join the rest of the group. And just traversing through the airports, although they were very quiet, we considered those high-risk environments and had the whole party wearing masks, gloves, and moving with extreme caution and good physical distancing and sanitising everything, essentially. We also asked for a private plane to fly to England, just to minimise the risk of exposure to COVID while on the flight. And something that we had to think about, was organising swabs and self-isolation for the flight crew. Prior to departure, they'd flown in from France, and so it fell on the medical team to organise all of that. On board, it was a pretty different experience too. The crew had very minimal interaction with us, as per our request, and the crew wore face shields, masks and gloves throughout the whole service. The playing group and the staff group were also required to wear masks for the whole duration of this long sort of 24-hour flight, which was an uncomfortable experience for some of them, but they got through it. When we got to England, the biosecure hub that the English Cricket Board had set up was really well thought through and sort of immediately obvious to anyone that was in it. No one was allowed to leave the biosecure hub at any point during the 6-week tour, and it was sort of very secure and well locked down. When we arrived, we all had our temperatures checked, and we were given a Bluetooth geolocation tag that essentially monitored our whereabouts at any point during the hub, and also monitored our contacts with one another so that contact tracing could be performed later if necessary. As I say, the whole hub was set up really well, and we were required to wear masks at all times when indoors, and also to physically distance at all times, essentially as much as possible during the whole 6 weeks of our travel there. The staff were divided into having various zoning access. So the staff that we were immediately came into contact with were members of Zone 1, and then you had Zone 2 and 3 towards the peripheries, and that was designed so that if one person did contract COVID, then it wouldn't sort of immediately require the whole operation to self-isolate, and that worked for the most part quite well. The furniture around the hub and the whole hub design was set up so that it was really easy to sit down and to maintain these physical distances from each other and from staff members at all times. And on the whole, it actually worked really well. Both the staff members in these hubs and the playing groups and the officials and everyone that was involved was swabbed for COVID every 4 to 5 days throughout the whole stay. So that was a large number of swabs across the whole tour, which thankfully for all of us came back negative. We weren't allowed to leave the bubble, as I say, but we were well looked after in these hubs. They had games rooms and entertainment rooms, and in Southampton at the Ageas Bowl, we did actually have access to a local golf course, which we were able to make safe and give the players and the staff members access to a bit of golf from time to time, which was much appreciated. The training and matches were quite different too. In terms of the training, we had a few different training protocols. We had a one skin, one ball policy, so that you could only handle the ball that you attended and took to training. And for matches, there were a whole number of different rules. The ICC introduced a rule where no player was allowed to apply saliva to the balls, and if any batsman hit a ball up into the stands, then the fielding team had to go and retrieve that ball themselves. They weren't allowed to have it thrown to them by any member of the crew or the ground staff. The seating arrangements in the changing rooms also dictated physical distancing, and as such we had limits to the occupancy of the changing rooms. So no full team could be in any one changing room at any one time, which meant that we weren't able to have team talks and a lot of the things you kind of take for granted when you're on in an elite tour like this. For those of you that follow it, you'll know that we ended up winning the ODI series, and it was really a great end to what was a great and a terrific tour, really. It wasn't over for all of us at that point, though. Those players that were playing in the IPL went on to fly to Dubai, and the rest of us got back on a plane and went straight back to South Australia, where we quarantined for 2 weeks in the Adelaide Oval Hotel, which was recently opened. That was actually a really good experience. We were very well looked after by the Adelaide Oval Hotel staff, and the players got to actually experience training every day via some exemptions that were kindly granted. And I think everyone coped really well with that, and I have no doubt they would happily do it again if the time came calling. In summary, a lot of work and planning went into a tour like this, but on the whole it was a great success, and it returned Australian international cricket to all of our television screens, and I was very proud to be involved with it. Thanks very much.
Well, that was a very interesting talk from Lee. I mean, I've never actually travelled as a sports medicine physician with one of the teams, so clearly you guys are going to have a lot more experience with it than I have. What are your thoughts on travelling with a team in this day and age?
I think it's tricky. The reminder from Lee is something that we may have forgotten, and that is when an infectious disease exists, it's highly transmissible. You have to assume that your exposure is high and take all those precautions. I remember many years ago working as a junior rugby doctor and discovering this condition called scrumpox or herpes gladiatorum that would rip through players and be a problem to yourself and others. I think for physios that are touring and travelling with teams, what we've learned from this COVID era is the importance again and again and again of your hand washing, your distancing and external protection. So for Lee, there's
the distance in a rugby tackle, John.
Well, with the National Rugby League, that was a bit of the tension about restarting the game early when people in the community couldn't. But that concept of going into a bubble, which does create some unique stresses, and also monitoring and doing lots of testing, it's essential if you're going to do something like that at the moment. Paul?
I think none of us can wait for the day when travelling with a sporting team and the worst thing that we're worried about is about a gastro from norovirus running through the bus. I think we're all looking for the day when that will be our worst fear again.
Indeed. Well, we look forward to it. Thanks, guys. Our next speaker is Dr. Samia Lakis, who is an orthopaedic spinal surgeon who does both adult and pediatric surgery. And today she's talking to us about scoliosis, which really is life-changing surgery for the people that need it. Thank you, Samia.
Good afternoon all. My name is Samia Lakis and I'm here to discuss vertebral body tethering in its essence. Tethering in itself can refer to spinal cord tethering, which is a form of spina bifida or spinal dysraphism, and really is managed by the Spina Bifida Clinic. Whereas vertebral body tethering is a surgical technique popularised really in the last 10 years by San Diego surgeon Peter Newton. And whilst he did a lot of the animal and original surgical procedures in this regard, it's grown beyond his control, and he's watched it popularised at various institutions, including other institutions in Germany and Turkey, and expanded within its technique. So is it new? And the answer is no. It's a strategy that's been discussed since the 1950s with previous forms as hemiepiphyseodesis, so unilateral screws and rods, and anterior vertebral body staple. However, there were problems with loosening and under correction, as staples really only seem to work on the more moderate flexible curves, and despite this they loosened and migrated. This original article looking at the potential is well worth a read. The best article and the sanest article that I'd recommend that you read would be this one published by Peter just this year. It's an open access article, and he clearly defines the goals to limit deformity progression and produce a correction to create a more normal spinal contour. He describes the aim is to preserve function and motion through these segments, and to try and do this through creating healthy discs, as our other alternate for these curves or severe curves or operative curves would be a fusion, whether it's performed anteriorly or posteriorly, is dependent on the curve or the surgical experience of the centre. So vertebral body tethering is a growth modulation technique, and there's good evidence on basic science data in animal experimental studies, and also increasing clinical evidence in patient cohorts and populations. So the principles are that a screw is placed across the anterior vertebral bodies in a plane relative to the scoliotic deformity, with care to not overly penetrate the other side and cause problems with the aorta and other larger vessels, or be careful with rotation so you don't end up in the canal or anything concerning. And then once those screws are placed, a ultra high molecular weight polyethylene weave, or tether as it's called, is tensioned across. And the idea is that this flexible tether facilitates disc health and nutrition. So we get compression across the convexity, or the outside of the curve, and this detensions the concavity and allows that to grow out. And it's this application of the Heuter-Volkmann principle which has been shown to actually be effective, although unpredictable, unfortunately. So what you see here is evidence of a standard right thoracic curve, a Lenke 1A, as we'd call it in the classification system. And the growth modulation is thought to be increased pressures on the concavity and decreased pressures on the convexity, meaning that there's less growth anteriorly in the end plates on the concavity and more on the convexity. And the idea is to reverse that through use of the tether and allow it to grow out. And the hope is that this would be predictable, but unfortunately it's not. As any growth modulation strategy in the body and the spine is unpredictable and has complications, unfortunately. So who benefits? Currently the literature would suggest a curve of 45 to 65 degrees in a Sanders 3-4 patient with relative flattening, not kyphosis, as an anterior compression force will increase the kyphosis. So the classic lordotic or flat adolescent idiopathic curve is the best one. The difficulty is you can't operate too young, and that's why the Sanders score or a left-hand bone age is important, because you can overcorrect it. The curve actually still needs to be flexible, with some proponents suggesting bending down to less than 30 degrees, as the bigger curves or the stiffer curves seem to break all the time, which is unfortunate, as it's really these young adolescents that are needing potential growth modulation to be of benefit to them as they're looking at early fusion. With regards to curve pattern, thoracic curves are amenable, but not the high thoracic. Thoracolumbar curves are also amenable, but the question is what to do with those big S-shaped curves or double major curves or the lumbar curves, as the increased mobility in the lumbar spine is associated with the higher tether breakage. And some proponents are now putting 2 screws and 2 tethers in the lumbar spine to try and decrease breakage rates. However, I can't see this as being fusionless or facilitating motion, although the jury's still out, really. So what are the risks? The risks are that of anterior surgery, whether you do it thoracoscopic or mini-open, whether you do it thoracic, cross the diaphragm or into the abdomen. There's a very high fluoro time, so increased radiation dose for these young individuals. And there's a steep learning curve with some of the technical considerations discussed previously. Thoracic curves, it's very hard to go above T5 as you end up in the axilla. And curves above this, or elevation of the left shoulder or an upper thoracic curve, you can't access it as you're ending up just above the just higher than the axilla and potentially into the neck. So short to medium term data suggests that there's risks of overcorrection, undercorrection, tether breakage, and there's a chance of conversion to fusion. So you have to have a patient cohort that understands these risks and understands that their potential is for revision surgery. And this isn't for everyone, especially when it comes to spinal surgery. So this is an example of a young patient, clearly open triradiates, those growth plates in and around the hips, and good result initially, and then evidence of overcorrection. And this can produce a significant clinical deformity. and requires revision surgery to basically release that tether with a small rebound. So with regards to the evidence, there's several cohorts that are well worth looking at, and the published studies are minimal despite all the talk. So Samdani and al. Looked at 32 patients. They did an initial preliminary one, but this is well worth mentioning, with an average COP of 43 degrees, and they got it down to 18 degrees at 1 year. Cabeto showed that out of 20 patients, they were looking at the higher ranges, and they got 60 degrees on average down to 23 degrees at 2 years. And Peter Newton published on 17 patients with an average of 52 degrees down to 27 degrees at 2 to 4 years. Samdani et al. Presented recently in the SRS just last year, 53 patients who had a COB of 40 degrees. That was down to 16 at 4 years. However, the 40 degrees was average, which suggests that they're operating on very low curves originally. So the challenges, as mentioned previously, are the high thoracic curves with access. For all thoracolumbar curves, you'd need to cross the diaphragm, which we're all comfortable doing if we do anterior surgery. And consideration of how to instrument the lumbar curves. We now know that you need to overlap your tether, so you're needing access on both sides. And in the lumbar curves, the question is, do you end at 3 or 4? And a lot of them are ending at 4, whereas we avoid instrumenting down to 4 wherever possible if we're doing a fusion. And if you're using double screws and double tethers and they fail, then that leaves you in a very difficult position. So what happens if you Google VBT? Well, the first thing that comes up is velocity based training, which might be of relevance to all of the physios and everyone here, however isn't really what you were talking about. However, Google offers you an option of VBT surgery, and you find lots of advertising from this group where she was smiling right after surgery, to some of the allied health where we're having the chiropractors really advertise their linkages with surgeons and promoting VBT as a better option. And if you look at the type of curves that they're operating on, some of them are quite small magnitude curves, which we would traditionally consider bracing in these curves. And bracing has a 70 to 80% success rate depending on compliance. So with a very low number needed to treat, you're treating 3 patients to avoid 1 surgery, and the cost of bracing is probably less than that of spinal surgery. Other groups such as this group offer to review your case from all around the world and call their surgery anterior scoliosis correction, not VBT, as they offer this surgery, as I said, all around the world, but to all patients, including the big stiff curves, and to adults. When you look at the fine print, they talk about spinal realignment, and they also talk about additional advanced corrective techniques for these inflexible curves, which in reality is a discectomy. And this is a technique that we're all comfortable with as spine surgeons, but the reality is that it creates a fusion. So looking at this as fusionless surgery is probably a bit misleading. So what about the Australian experience? Look, Jeff Askin in Brisbane pioneered thoracoscopic anterior fusion and has a very skilled team up there, and he's extended this successfully to VBT surgery, but mainly in the thoracic group. Jeff will happily go down to L2. Andrew Cree in Sydney has probably the largest case series in Australia, with a preliminary presentation of results at Queenstown. However, it's a very early experience. And I'm aware of some surgeons performing it in Melbourne and Adelaide. The costings is questionable, as for paediatrics there's no rebatable code under MBS, and as far as I'm aware the tether's not listed under the prosthesis list, so that's an out-of-pocket expense for the patient. So just to show you that it's not the only device available, I think the utilisation of fusionless surgery or internal correction implants, as this ApiFix is expanding the market. So for the more moderate curves or low-grade severe, if you use the cutoff for severe as operative, there are a number of alternatives promoting themselves. However, they only have short-term data, and in this regard, the device here is only really advertised or promoted by user groups associated with the company. So we'll need to work this one out further. In conclusion, look, tethering is promising as a growth modulation surgery. It is experimental, and the ideal indication long-term outcomes are still to be identified. You need patients that are keen to be on the cutting edge and happy to have revision surgery, as that's the very real risk. There are a number of alternate options for the moderate or flexible curve, and my concern is that we're going to translate previous patients who would be braced or non-operative into operative, and this will come at increased cost to limited health resources and potentially to increase risk to the patients themselves. I think translation into the adult skeletally mature market should be met with scepticism for the reasons previously elaborated. Thank you for your time. Any questions?
Look, as a surgeon, I found that really worthwhile reinforcing the message there that not all cases that can be operated should be operated on, because a lot of patients will do very well with bracing. I guess it's really a question of catching the curve early enough, isn't it?
Well, certainly. I mean, we know that if you're skeletally immature, then the risk of progression is much, much higher. But I think there's also some changes in how scoliosis has been detected in compared to in decades gone by. I'm not sure if you recall, John, it used to be pretty standard that children would be screened for scoliosis at school.
It certainly was around as I started school, and then it seemed to vanish. So I think there has been undiagnosed scoliosis in the community, and I love the way Sammy just methodically went through the criteria, non-operative, and then some of the new surgeries. It's very, very big and brave surgery, I must say, but it's not a diagnosis you want to miss. So I think in doubt, just helping our audience view again, if they have to, the criteria for referral, and there's no harm in doing that.
And I guess, given that we no longer have, public screening programs like they used to have, physios are probably in the box seat as a health profession to actually identify it in the younger population and to refer early. So it's really important that physios are actually aware of the referral criteria, because this is another one of those conditions where early management leads to better management.
Yeah, and it really can be life-changing surgery for these people in terms of preventing the long-term respiratory problems and spine arthritis problems. So very worthwhile doing.
Mm.
All right, thank you. Our next speaker is Dr. John McGreen, who is a specialist foot and ankle surgeon. John was the past president of the Foot and Ankle Society and has a wealth of experience with foot and ankle conditions, and he's just talking to us about 3 illustrative cases today. Thanks, John.
Greetings, ladies and gentlemen. I would like to present 3 cases that illustrate the importance of making a diagnosis. The first case is an unusual cause of heel pain. This gentleman came into my office. He was 26 years old, and he had had a sore heel for 18 months. The pain was global, not on the plantar side. It occurred day and night. He had no history of penetrating injury, drug abuse, or any form of systemic malaise. Examination: the patient was blind. His gait was normal. He was able to take weight on the foot. He had a slight swelling on the lateral border of the heel and calf and a little bit of tenderness laterally. had a normal range of motion in the ankle and subtalar joints. Plain x-rays taken certainly showed a little bit of lucency in the lateral calcaneus, which you could see on the lateral and the axial views. CT scan, once again a lucent area in the calcaneus. MRI scan, quite a deal of bone marrow edema, expansion of the lateral wall. Highly abnormal. Question: how did the man become blind? Answer: he had had retinoblastoma in childhood, with enucleation of one eye at age 2 and the second eye at age 4. I got in contact with the Children's Hospital where he had had his surgery, and he was originally treated and had chromosome analysis, which had advised us that his chromosome anomaly was the 13RB1 locus anomaly, which I'm sure you're all familiar with, and that this anomaly particularly predisposed him to osteosarcoma later in life. He underwent a biopsy, and in fact the poor chap had a metastatic retinoblastoma, and he's currently undergoing chemotherapy. Second case, a 54-year-old gentleman got his foot caught at work. No snap or pop in the ankle or Achilles region. Examination: he walked with a marked limp and had a palpable defect with a positive Thompson test. He came in with an ultrasound suggesting an Achilles tendon rupture, and no plain x-rays were taken. The people that saw him placed him in a boot, but naturally he found the boot uncomfortable, so he took it off in bed and took it off in the shower. I saw him in consultation and I didn't like the look of it, so I took a plain x-ray, and the plain x-ray shows calcification some 4 centimeters above the Achilles insertion. So in fact what he had done was avulsed the Achilles insertion, and the Achilles was sitting halfway up his leg. This patient would never have healed in a boot, and the surgical repair was certainly mandatory. Third case, a 35-year-old gentleman who was doing Thai boxing in February noticed pain and swelling beneath the second MTP joint, lasting approximately 6 months. On examination, he walked easily on heels but less easily on toes, and there was a slight splaying of the second and third toes. He was tender at the insertion of the plantar plate at the base of the proximal phalanx, and the joint felt mildly unstable. I took a plain x-ray and noticed once again splaying of the second and third toes, see the gap between, and he had an MRI scan performed which showed bone marrow edema at the base of the phalanx and an obvious tear of the second plantar plate. So the diagnosis here was a second plantar plate tear, unusual in 30-year-olds but does occur occasionally. Treatment initially, taping, insole, avoidance of impact, surgery if not responding. Take-home messages: there is absolutely no substitute for a good history and physical examination. All 3 of these cases had abnormal plain x-rays, and only one of the patient had had an x-ray. The adage in medicine that you see what you look for and recognize what you know is absolutely critical, and always try to make a diagnosis before you suggest treatment.
I've got to say, I think I enjoy John de Green's talks when I don't see him. What do you guys think about that?
Well, he's always got an interesting fashion sense when he comes to our live lectures.
But you can see he actually did the photo with the new haircut right at the end there. I think he was in the middle, wasn't he?
He certainly did.
No, look, in all seriousness, John always presents so well, and his strong points on x-rays were helpful with his cases. Do you feel that is something that should be reinforced, particularly with plantar plate trauma?
Well, look, with plantar plate trauma, I mean, that's a tricky one. And I mean, the separation of the metatarsal heads or the toes is actually a fairly subtle sign on x-ray. So I think it's more illustrative of the point that we often don't analyse x-rays or assess them accurately. But I mean, I probably wouldn't be relying on it for that diagnosis. But I think it does speak to the point, and this is in line with your campaign that we really, for such a simple and cheap investigation, we probably should be doing more x-rays. And it's something that you don't need to be a doctor to order. So therapists can order them.
Yeah. And the important thing about any investigation, as you guys know, is that the investigation is targeted to look for a particular diagnosis. It's not a screening tool. So you have to have taken a good history, and as John said in his talk, examined the patient, made a diagnosis, and then that's what your imaging is designed to confirm, rather than just trying to screen for everything. And I think perhaps that's why a lot of people are going straight to MRI scan these days, because it captures everything and you don't really need to examine the patient all that well. But the problem is with the MR findings, that they're so broad that sometimes it doesn't help and you need to come back to the patient once more.
Yeah, and I think probably with regards to the Achilles avulsion too, that really speaks to the point that management can actually be different. So if you've got an avulsed fragment of bone that's retracted that far, it doesn't matter, how long you immobilize for or what degree of plantar flexion you immobilize in. That fragment's never going to get back to where it's meant to be.
Yeah. That's a big point. I think that's a huge take home. I strongly would endorse that.
And that's not to discredit or discount the role of conservative management for Achilles tendon ruptures, because we all know there is a role for that, but it's nice to be able to stratify it between the patients who are going to benefit from that and who will do well from that, and from the patients who clearly won't.
All right, well, fantastic. I enjoyed John's talk. We'll now move on.
It's great to have Dr. Rod Pattinson back with us. A long time between presentations, Rod. Rod's going to be talking to us about slipped upper femoral epiphysis. Rod's worked for decades at the Sydney Children's Hospital, and although he sees adult patients, he's had tremendous expertise in gait abnormality, talipes, and spasticity treatment. And one big part of Rod's CV is for the 28th year in a row, he's been chair and organiser of our golf day. So we look forward to Rod's presentation. Thank you, Rod.
Thanks, Rod.
Hi, everyone. Thanks for registering and coming to our lectures. My name's Rod Pattinson, and I'm going to talk about slipped upper femoral epiphysis today. I'd like to look at it as a case study. A 15-year-old boy presents with left knee pain and a limp a week after coming off his bike. For 2 months he's had a sore left knee on and off after football, and his mum has noticed him limping from time to time. He's had some chiropractic treatment for his knee, and an x-ray of his knee showed some changes of Osgood-Schlatter's disease. The boy walks with an antalgic gait and a limp, and he walks with his left foot a little externally rotated. He has a positive Trendelenburg sign, so when we ask him to stand on his left leg, the pelvis drops on the right, indicating there's a mechanical problem with the left hip. He lies supine with his left leg in slight external rotation, and there's no swelling or tenderness around the left knee. There's 1 centimetre of shortening of the left leg. There's a normal range of motion of the left knee and no tenderness, and on flexing his left hip, the leg goes into abduction and external rotation. Attempts at internal rotation at that position cause knee pain. X-rays of the left knee show irregularity of the tibial tubercle apophysis, and X-rays of the left hip show a grade 1 slip, less than 30% displacement of the upper femoral epiphysis. This is the AP pelvis X-ray, and you'll note that the growth plate on the left here, at the red arrow, looks wider and irregular compared to the other side. This is what's called a frog leg lateral view of the hip, and this is the important X-ray. Note that the epiphysis, where the asterisk is, looks like a scoop of ice cream falling backwards off a cone. It's that posterior displacement that causes the external rotation and abduction deformity. The boy is placed on crutches touch weight bearing and referred to a surgeon for pinning of the hip in situ as a semi-urgent referral. That operation involves passing a cannulated screw across the centre of the growth plate under X-ray image intensification. It can be done as a day-stay operation. Here's a view of the pelvis showing a pinned left hip. Slipped epiphysis is a semi-urgent problem that can cause serious hip deformity predisposing to premature osteoarthritis. The diagnosis is commonly delayed. The presentation can be chronic, more than 6 weeks, acute, or acute on chronic. It's more common in overweight and active teenagers, but also occurs in normal weight, sporty kids. Pinning in situ prevents further displacement and encourages growth plate closure. Excessive deformity of the femur may require treatment by osteotomy after pinning. The pain felt in the knee is referred pain from the hip via the femoral nerve. Importantly, both hips may be affected in up to 30% of patients, and the patient and carers should be warned to return if symptoms develop on the other side. Key points to take home are that any adolescent with thigh or knee pain and/or a limp should be considered to have a slipped epiphysis until proven otherwise. The treatment of choice is pinning in situ as a semi-urgent procedure, and post-operatively the patient should use crutches part weight bearing until there's evidence of growth plate narrowing on X-ray. That usually takes at least 6 weeks. Thanks very much for listening and for coming to our lectures. Bye.
Well, thanks, Rod. That was a great talk, and it's really fantastic to have you part of this year's lectures again. I know you have lectured before with us, but it's been a little while. And one of the things that I really liked the message that you gave was the presentation of knee pain. If you examine the knee and you can't find anything wrong with it, you really need to go up to the next joint up, which is the hip joint. John, your thoughts on other potential diagnoses around the hip?
Look, obviously with Rod, the externally rotated limb is a giveaway, but in the back of our mind, we need to think of Perthes disease in that age group. Bone stress injuries are a possibility in an overuse setting. Rarely you would look at labral tearing and impingement in that age group, so a caution against just sending people off for an ultrasound or MRI, again, pushing plain films there. But I think with that history, with the external rotation of the limb, with the normal knee examination, I think Rod did a good job in reinforcing that important diagnosis.
And
do you have any extra thoughts?
Yeah, look, I think we get an important learning point out of Rod's lecture there. And I think that's again on X-rays and the importance of doing the right X-rays. So in the skeletally immature population, we have these growth plates that can sometimes look like fractures, sometimes they can be quite atypical, and we don't really know what's normal. So it's always useful in the juvenile population to order bilateral X-rays so you can compare with a contralateral limb and determine exactly whether they're symmetric. And it's really asymmetry of the growth plates there that really raises the alarm.
All right, very good points, guys. Thank you. Well, what a great morning it's been. Thank you so much for sharing your morning with us on this YouTube live stream. We've certainly learnt a lot doing it, and we hope that there weren't too many technological problems for you guys and that the audio was okay. Thanks so much, Paul and John, for your involvement as well, and to the rest of the speakers for giving up their time to share their information with you today. If you do need an ongoing education certificate, please email Orthosports 2020 to Catherine, and she'll be happy to provide one for you over the next few weeks. Now, we have over 1,100 people registered, so it might take a little while to get your certificate, but don't worry, it will come, and we very much look forward to seeing you again next year, hopefully in person at the auditorium, but failing that, more online education and sharing with you. Thanks so much, and bye-bye.